I am excited here today to be here today to discuss some exciting sciences. So I'm not gonna drag this out long. I just wanted to say welcome to everybody. We're happy to have you here. Make sure you silence your devices so we don't hear binging or anything else that could distract the speakers. Also, this meeting is being recorded, and this is a hybrid meeting. We do have virtual attendees watching through videocast. So when you're asking questions, please come to the mic so that we can have those questions heard online as well. So with that, and also for the virtual attendees, you also can submit your questions through the videocast Q&A option. So look for that box on your videocast window, and please submit your questions and we'll read those out as time allows. So with no further ado, I'd like to introduce and welcome Dr. Tara Schwetz, who is the NIH Deputy Director for Program Coordination, Planning, and Strategic Initiatives in the Office of the Director of NIH. Tara joined back in 2012, and she has held multiple positions across several institutes and within the Office of the Director of NIH. And most importantly, she started her career as a AAAS fellow in NINR. Sorry, I had to get my AAAS fellow call out there. And with that, no further ado, I'd love to welcome Tara up here to open us up.
Great. Thank you, Dana. Let's see. Somehow I automatically already turned the slides, so off to a great start. Well, good afternoon, everyone. Had to think about where we were in the day here, but I guess those online, there's probably a few folks that are still in the morning. As Dana said, I'm Tara Schwetz, I'm the NIH Deputy Director of Program Coordination, Planning, and Strategic Initiatives. That also makes me the Director of a similarly named division, the Division of Program Coordination, Planning, and Strategic Initiatives. We lovingly call it DPCPC. I am thrilled to be here to welcome you all to the 2024 Behavioral and Social Sciences Research Festival, which is here on campus. And my title that you can see on the screen here is really celebrating behavioral and social sciences, because that's exactly why we're here. And that's what this festival is all about, to be able to celebrate and uplift and learn about all of the amazing behavioral and social sciences research that is being conducted across the country and supported by NIH, and that are helping to transform our understanding and approach to health. So those of you who stayed up late last night, we're going to keep you engaged because you're going to hear some really interesting and innovative science, okay? All right, well, let me jump in and just talk a little bit about the Research Festival and why we're here. So an NIH-wide research festival, not just one that is convened out of OBSSR, but this is really a team effort here. And there was a dedicated subcommittee of the OBSSR that is the Behavioral and Social Sciences Research Coordinating Committee. And they convened and really helped to pull this event together. And this is really evidenced by the broad range of ICOs, or institute centers and offices, that are represented on this slide and supporting this effort, and our speakers here from NIA to NINR and a lot in between. All right, and we know that behavioral social science research is critical to public health. I feel like I'm preaching to the choir here when I tell you all that, but I think this slide in particular really helps to illustrate that point, because we know that many of the leading causes of mortality actually have modifiable risk factors that are sort of based in behavioral and social science research. And when you look at those, you know, just think about all of the things that we could do to help try to bring down those numbers. And that includes supporting a robust research portfolio in behavioral and social science to help us understand and treat and prevent morbidity and mortality in the United States, and help to translate that research into findings that really actually impact practice and have an impact on people's lives and their health. And I think Behavioral and social science community has known this for a really long time, I think over the last several years. The rest of the biomedical research community has really started to recognize and embrace this a little bit further. If you build it, they will come approach. I think people are recognize that that doesn't work, and that there's a lot more to it than that. So we are fortunate to have a range of speakers who are going to talk about some really exciting and cutting edge examples of how behavioral and social sciences are addressing our nation's most pressing health challenges. Whether we're thinking about from adherence to vaccine campaigns, behavioral and social sciences research plays an essential role in tackling these challenges. So these are just a snippet of some of the topics you're going to hear about today. All right, we know that behavioral and social sciences research is highly complex, cuts across a variety of different levels of the social ecological model. And the studies that are incorporated in there and the complex social context within this really helps to consider a lot of different areas, whether we're talking about the individual person level all the way up to the community, or where especially the federal government can play a larger role is at the policy level. And then again, everything in between. And that approach really, I think, helps to focus in on things like social determinants of health and structural factors that can help to influence health inequities. All right, so recognizing this, a couple of years ago, a Council of Councils working group determined that one way to optimally appreciate and realize the benefits of behavioral and social sciences research is to integrate it across NIH at a variety of different levels. So whether we're talking about the workforce or the research that we support, those are two things, but also thinking about our policies, our practices, our priorities, and how we can continue to lift up behavioral social sciences and integrate that into each and every one of those areas. And I think today's research festival helps to underscore the value of integrating behavioral and social sciences research into everything that we do. So as I mentioned, the best treatments are not going to be are as robust as they need to be if people are not using them. If you have limited accessibility, if you have limited uptake, and limited distribution, then you're not getting the tools and treatments out to those who need it. So we know that early and frequent and systemic integration of behavioral and social sciences into the work of NIH is essential for successful public health research. So with that, I'm going to be brief, as I said. So I'm actually done, and I am going to now turn it over to Dr. Jane Simoni, and she's going to talk a little bit about the Office of Behavioral and Social Sciences Research and the work that they do. And Jane is the Associate Director for Behavioral and Social Sciences and the Director of the Office of Behavioral and Social Sciences Research. And she joined NIH in 2023, so last year. She came to us from the University of Washington, where she was a professor and director of clinical training in the Department of Psychology and the founding director of the University of Washington Behavioral Research Center for HIV. And Jane, of course, is responsible for advancing and coordinating the efforts of OBSSR and helping to convene and work with all of the institutes and centers across NIH to promote behavioral and social sciences research. So glad to have Jane here for the last year and a half. And I will turn the stage over to you all. So I hope you guys have a really great meeting today.
Hello, everyone. Good day or good afternoon or good morning as it is. It's wonderful to see so many of you online and to have so many of you here in person. It's great to be together, especially this morning. There is something that we overlooked this morning. This is not just an Office of Behavioral and Social Science. This is across all NIH Behavioral and Social Science, as Dr. Schwartz pointed out, but I neglected Dana to give thanks to the coordinating committee. I'm sure we'll do this at the end as well, but I can't start this without saying Dana Slosh. I don't know if Mike Spittle is in the is Mike here in the audience right now? He can stand up. Lizette Rivera, Kathy Malsby. There were a couple others, and I'm sure all the people that were across. You can stand up. You guys are so shy. Stand up, and we can see you here in the room. Thank you. Stand up. I've ever seen, but yes, that well-deserved. Yeah, yep, and we'll do a little more formal thing at the end too, well, but it was great, and people across all the different agencies are involved, so thank you so much for the work you did putting this together. All right, today I'm going to talk about a little bit broadly about our health situation in the US, and then talk about our office, and I've entitled this Unrivaled Opportunity because I think in many ways it really is. Okay, I'm finding the one that'll make it go down. Huge down, full keyboard. Yeah, that one. Okay, that one. Okay. Yeah, down arrow is very difficult. Okay, so the state of the nation's health, as Dr. Monica Bertinoli, our director, has said, isn't a word, or two, it's not good. The US ranks poorly in overall health compared to other high-income countries. Indeed, the US ranks last among the 11 higher income nations on healthcare outcomes, administrative efficiency, and access to care. And we can see this in different conditions. On the left is percent of total population that is obese, higher than our peers, percent of adults age 18 and older who have multiple chronic conditions is a third of the population. In terms of infant and maternal deaths, per 100,000, 5.4 in the US, and then particularly shameful maternal mortality deaths, 23 per 100,000 live births. Deaths from assault, often due to firearm violence, is 7.4 for 100,000, astronomically higher than our peer nations. And all this adds up to overall declined life expectancy in the United States, which is only 77.5 years. Again, the closest is over 3 years beyond this, the lowest life expectancy among all the wealthy nations. And on top of this, not only is health not great in the United States, but there are major disparities in health outcomes by race, ethnicity, by socioeconomic status, and intersectionality among all these factors. So even just taking a brief look at these in terms of life expectancy by race, much lower for minoritized populations because long-standing inequalities have contributed to these poor health and disease outcomes. And this really hasn't changed. We can look at Black and white differences here for the last 70 years or so. There's a steady and persistent disparity that has not diminished. When we look at relative risk at all cause mortality at any age, we can see that the odds are 3 times greater if you're not making $115,000 a year, but are making less than $25,000 a year. And as I said, there's intersectionality. So race and race, ethnicity, and income are not separate. And you can see in 2018, these numbers again, minoritized populations, Hispanic, Native American, Black, lower incomes than a white and Asian. And again, this hasn't really changed in the last 50, 60 years. Over time, there's been steady increase overall, but the disparities continue to persist. And is it that we're not spending enough money, not putting the money, maybe not putting it in the right place, but certainly total number of and expenditure for health outcomes is not the reason why. In fact, the US is, in terms of health spending, is nearly double that of comparable nations, as you can see per capita here. And spending 4,000 more per capita on health than the next highest spending health country. And in the end, we still have a gap. Despite this high spending, the life expectancy is poor. I don't know, is this mouse, can you guys see this? No, but you can see that gap between the amount of spending and the overall health expectancy. The leading causes, so what is killing us exactly? Let's look at a little more closely. Dr. Schwartz mentioned some of these, the leading causes of mortality in the United States. These will be familiar to those in the health field: heart disease, cancer, unintentional injury, COVID over the last few years, and other diseases. But when I look at this list of mortality in the United States, what strikes me is the behavioral and social science factors that influence almost every single one of them. The behavioral factors, it's worth enumerating them: poor diet, physical inactivity, smoking, excessive alcohol consumption, sun exposure, and other risky behaviors like unsafe sex, not wearing seatbelts, driving under the influence, and unsafe work practices, as well as limited vaccine uptake. And then in terms of the social or structural factors, because we have to look at this from an ecological perspective, we have social isolation, which is lethal, limited access to healthful foods and safe places for physical activity, limited access to preventive services and quality healthcare. And then environmental and occupation exposure to toxins and pollutants. Finally, income and educational levels. As we say, this impacts everything in terms of the disparities. So these are not factors that we can't change. We can address them. These are amenable to our interventions. And we have done this. Behavior and social science research has shaped health policy and improved health outcomes overall, from everything to vaccine campaigns, adherence to medication treatment, a field I worked in HIV, to mental health interventions, smoking cessation. All of these fields have been impacted by behavior and social sciences, with direct implications for policies that can decrease the disparities and the structural factors that influence these outcomes. Now, in the past, one of our directors has said that maybe despite these glaring instances of how behavioral and social sciences can have an impact on health, that maybe we underinvested in research on human behavior. And that may have showed up in the COVID epidemic, where still 1 out of 5 people have not ever received a COVID vaccine. Nevertheless, now I feel helpful. I said this is an unrivaled opportunity at NIH, and 3 things have happened in the last couple of years have made me feel this way. The first is our NIH strategic plan update. We now have expanded the biomedical research mission to include biomedical and behavioral research. That's at the very top of our plan, and it cuts across everything we do at NIH. Second, I had the pleasure of working with the Social Behavioral Science Committee of the Office of Science and Technology at the White House on a blueprint for the use of social and behavioral science. There's been a focus on evidence-based policymaking, and this blueprint for the use of social and behavioral science is going to help guide us in that regard. And there were recommendations aimed at all the federal agencies to improve policymaking by relying on the science. And finally, the integration report that Dr. Schwetz mentioned, the Council of Councils, or overriding council at NIH. This was a congressionally mandated report that said, hey, you have underestimated a bit in social science. We want this integrated into everything we do. We want you to tell us how you're going to do that, and we do monitor that. So now let's switch focus a little bit, talk about our office in particular. So the Office of Behavioral and Social Science Research was created by Congress, and it initiated in 1993, opened their doors in 1995 with a broad mission: coordinate all the health relevant behavioral and social science, and identify some challenges and opportunities that are there so that we can address them with the best, I call it BSSR. And in terms of our charts, with the NIH, Congress put us right in the office of the director. All the 27 institutes are, I would kind of say, under this office of the director. So we really cut across. We are, as they say, disease agnostic. We focus across all of the institutes, whether it's cancer, diabetes, heart disease, Alzheimer's disease. We cut across all of them. So it's the behavioral and social science factors. And we work with the other 16 or so offices in the Steve Poughkeepsie office under Dr. Schwetz to address these issues. So we coordinate and oversee across all the other institutes. We have a diverse, though smallish team. We say we're the engine that could. We're multidisciplinary, very experienced, creative, industrious, and that's why we can do what we can do with a smaller budget. We cut across all the behavioral and social sciences in terms of our interdisciplinary expertise and our leadership team. And this year, we coordinated the first vision and mission as part of our new strategic plan. And I'll read them. Our vision really is the synergistic integration of BSSR into health research. And we believe this will lead to accelerated scientific discovery, more effective treatment and health promotion interventions, and equitable implementation strategies to improve health for everyone. And our mission, how are we going to do this? We're going to enhance the impact of BSSR by identifying gaps and opportunities, and that's both within NIH-funded research and in the fields in general. Integrating BSSR into the larger NIH mission, and that's what the strategic plan has said now. We're institutes for biomedical and behavioral research, and we're going to develop and coordinate BSSR initiatives within all of the institutes, centers, and offices at the NIH. And finally, we're going to communicate. We're going to communicate significant results both within NIH and beyond. Our budget is smaller. So when we look at the NIH overall, it's really close to almost 50 billion now. The NIH is the largest single public funder of biomedical and behavioral research in the world. Our budget is an order of magnitude or so lower at 41 million, but it's steadily been increasing with a bump during COVID. And we're proud to say that almost all of it, we invest in high quality, cutting edge behavioral and social science research that is administered by the institutes and centers at NIH. We had a strategic plan come out just a month ago. Our cross-cutting theme is health equity. That is that every individual should have an equal and just opportunity to pursue full health and well-being. And that undergirds everything that we do. And we looked at our priorities in terms of 3 areas: the research, the capacity, and operational. In terms of research, we're hoping to fund collaborative science. We really integrate and coordinate BSSR. We don't think these are 2 separate camps that need to fight with each other, but they work together in a team science approach. We're trying to build a cumulative knowledge base with an ontology program. We're enhancing and connecting the basic and applied BSSR. And then we want to look at scientific innovation and really think more innovatively about it. We want to refine our BSSR measurement, with which our ontologies program will help us to do. We want to promote novel experimental designs and advanced data analytics. We're particularly excited about how AI might be able to contribute to BSSR, both in terms of the interventions and the analysis. And finally, as Dr. Bertagnolli, our director, says, if we're not seeing the impact of our research, then our work isn't done yet. We are focused on research that will enhance implementation, dissemination, and equitable impact. So really encouraging rigorous and innovative research in this area and centering health equity in the work that we do. In terms of capacity, we want to build up the workforce, we want to improve organizational climate, both within our office and across the research teams that we support. And for operational strategies and policies, we are committed to DEIA values. We want to build collaborative partnerships, not just across the NIH, but outside the NIH as well, to expand our reach. And communication and outreach through our comms department is a very big part of what we want to do this year. We have some of these some hard copies too outside, so those of you who are in person are interested, please take a look at them. So I said we invest almost all our money. Where does it go? What do we do? Well, you can see over the last few years, there's been an increase, but last year alone, 32 million we invested in BSSR research. And our total grant co-funding, again, we operate through the institutes and centers at the NIH for last year. You can see cut across almost every single IC at the Institute, with most of our co-funding going towards the National Institute of Mental Health and Child and Human Development, with some for nursing and cancer as well. When we look at co-funding, we look at research that we'd like to support, we have a few priorities that we focus on every year based on the state of the field, what we think is important. No matter what the research, we're always interested, you can see in the box on the right, to be, especially support early stage investigators. It's more difficult than ever to begin and sustain a career in research. We want to support the young investigators. We want to foster diversity in the workplace on many levels. We want to incorporate community engaged approaches and voices. We want to address health equity disparities and populations who are understudied, underserved, and underrepresented. So that's in all the work we do. In terms of the particular subject matter that we're interested, number one, I think this is the sine qua non of behavioral and social science research, and that's behavior change and maintaining that behavior change. And that is a focus on intervention research. We're also interested in interpersonal relationships, social connectedness and isolation and loneliness. We're working with the Surgeon General's office on the initiative to look at this, and we're funding research on ways that we can enhance it. We also want to look at higher order contextual factors. You saw that nice chart that Dr. Schwetz showed that looks at social determinants of health, as well as the individual factors. And then the role of health communication and its impact on individual and group health outcomes. And finally, we're interested in artificial intelligence and how it interacts with behavioral social science and health research, and how we can leverage that to improve what we do in overall health. I'm going to end with just looking at some of the initiatives that we've worked on. We have a brain initiative. We do a lot of work in neuroscience. Dana heads up a lot of this. So supporting the development and validation of next generation platforms and analytic approaches to precisely quantify behaviors in humans and link them with simultaneously recorded brain activity. We have a huge violence research initiative. Congress has entrusted us with distributing the $12.5 million per year to look specifically at firearm violence prevention that we have done. We have an active basic behavioral social science research committee that came out of the OpNet program and identifies research in more basic areas that complement the interests and missions of the NIH institutes and centers. We have a COVID coordinating center that's in its 4th year now, providing a nexus for everything we've learned about the pandemic, with looking forward to being prepared for what inevitably will be another pandemic, and making sure we're better prepared with data to support what we do and avoid some of the disparities that we saw during COVID. We are looking at team science research and application of how to do it. We have a National Academies consensus study that began in August to look at the best ways to support team science. We have a behavioral ontologies program. We funded multiple grants this year to look at the role of ontologies, how we think about the structure of knowledge, not just the terminology, but the constructs underlying the field of behavioral and social science research, to help us come up with better measures and more effective ways to intervene. And here's just a map of what we're doing in terms of the firearms violence prevention research. We have funded a series of research network awards. These are all over the country in these different institutions to support the work we do and develop the workforce in this area. Remember that first chart of the deaths in the United States, how high they are. This is work that we hope will have a direct impact on that. We're proud to have the Matilda White Riley's Honors Lecture and Awards every spring, in which we look at early stage investigators have a paper competition and bring them to the campus, and a distinguished lecturer who addresses our community. We have this festival, which I don't need to say much about because you're all here now and know about it, but we're proud because it looks across the whole NIH. There's one thing I want to focus on this, really a broad range of both basic and applied research, and shows the work that the research that we have been investing in. And then we really are focused on training. Remember, it's one of our capacity awards. So we have the TADA program, the Advanced Data Analytics for Behavioral and Social Sciences, where we're training doctoral programs at the T32 to focus on very innovative computational and data science approach. Doing data science and analysis and behavioral and social science is different than it is in biomedical science. We need different tools, and we need to make sure that our workforce is funded to be able to learn these tools. We have a short course program on innovative methodologies and approaches called the R25 Independent Clinical Trials, not allowed, but it's for training and development of these different methods. And then we have a K-18, a Career Enhancement Award to advance research on firearm injury and mortality prevention. So all ways that we support training at various levels for workforce development. And then resources, you can look at, definitely look at our website, but we have a good clinical trial practice for social and behavioral research. Some of you probably taken that, you may have been required to do your study. We have a summer institute on randomized behavioral clinical trials. We have our director's webinar series throughout the year. And then in terms of our communication resources, again, check out our website. We have a director's spotlight where I highlight some of the key things that are going on at NIH and in the field. We have a technical assistant webinar series. We have funding opportunities that we highlight. We have a connector newsletter that tells you what we're doing, what's happening in NIH and the field. And we have research highlights of the best cutting edge BSSR that we are supporting over the course of the year. Upcoming events is our 30th anniversary that we'll start celebrating in January. There'll be more to come about this, but that will be a big theme of our festival next year. I'll end going back to this life expectancy chart, and the Reverend Dr. Martin Luther King said that the arc of the moral universe tends to bend towards justice. And I hope it's true in terms of, because of the work that we do, that this arc in terms of health also bends in the direction of decreasing health disparities. But as we saw, it won't change on its own. It's been pretty consistent for 56 years. It will take our work, it will take innovation, it will take dedication, collaboration in a interdisciplinary way, on a multi-level way, to really have an impact on health outcomes for all. And with that, I'll leave you to enjoy the conference. Thank you.
Terrific. Jane, you were a little too speedy, so we're a little bit ahead of schedule. And since our next panel is virtual and we have to have the virtual participants actually on the panel, I'm going to give you guys a little bit of a break So if you need to go to the restroom or grab something, just be back here at 1:45 and we will get started with the virtual panel. Okay, great. Thank you all for being patient and giving us a little break. Hopefully that got you up and stretching your legs a little bit. We are now ready for our panel, our keynote panel, and the moderator for this will be Dr. Tamara Hegarich, who is from the National Institute of Drug Abuse, and she will be introducing our first speaker in this session, and will also be moderating the Q&A discussion afterwards. Go ahead and take it away.
Great, thank you. Can you confirm you can hear me? Yes. Great, thanks so much. Well, thanks all of you for joining us for the keynote session on artificial intelligence in clinical medicine and public health. I'm Tamara Hegarich, and I'm on detail to OBSSR from the National Institute on Drug Abuse to focus on the intersections between AI and behavioral science and health. And it's my distinct pleasure to introduce our speakers today, Dr. Kirandeep Singh and Dr. Sandro Galea. Dr. Singh is a physician and chair in digital health innovation at UC San Diego School of Medicine and is the inaugural chief artificial intelligence officer at UC San Diego Health. His focus is on implementing health systems change that advances clinical outcomes and safety, with a focus on organizational approaches to integrate AI into clinical workflows and ensure that governance is in place for accountable AI. And his work has been cited in policy documents such as the White House Blueprint for Artificial Intelligence Bill of Rights, as well as HHS and NACIP guidance. And the title of Dr. Singh's presentation is Tackling the Health AI Paradox. He will be taking us on a journey through the early challenges faced by health systems implementing AI tools and the evolving policies and areas for potential health impact. Dr. Sandro Galea is a physician, epidemiologist, and author, and is a professor at Boston University School of Public Health. Dr. Galea is a widely cited scholar in the social sciences with funding from NIH and CDC and philanthropic foundations. His focus is on supporting public health through a focus on health determinants and access to care. His recent work has offered thought leadership in the integration of AI into public health to transform care at the population level, influencing surveillance, diagnosis, and treatment decisions. Dr. Galea's presentation is entitled AI and the Health of the Public, and he will speak to the importance of comprehensive and diverse data sets to inform policy effectiveness, balancing public health objectives with community preferences, aligning approaches with ethical standards, and addressing biases that can be embedded in AI systems. So we're going to start the session with the presentation by Dr. Galea, and then we'll pass the baton to Dr. Singh. And then we should have about 20 minutes at the end for some facilitated discussion and Q&A. For those of you that are on videocast, again, please feel free to submit questions that we can route to the presenters through the discussion session. And then we're also going to take some questions from the room at the end of the presentations. So without further delay, Dr. Galea, would you like to take it away?
Wonderful. Thank you. Thank you very much for having me. Let me share my screen. Very good. Thank you all for being here and for inviting me to be a part of this discussion. I actually think it's an interesting and exciting moment. Actually, think about AI and at the intersection with public health, and for all the reasons that we all know. And what I thought I would do is very briefly to talk a little bit about some of the challenges that I actually think emerge in the context of thinking about AI, to the end of course, pointing in positive, proactive directions. You know, there is, it's no surprise to anybody here that AI has taken the world literally by storm. This is actually from Google, and looking at sort of the multiple ways in which they actually are thinking about AI in the medical domain. And there is an endless stream, it seems, in the past 6 months of potential AI solutions intended to intersect with how we think about health. It's important to recognize this from a paper that was published in JAMA by a range of authors that you know, we'll talk about AI is not AI. There's been a whole range of AI developments. What we're largely talking about here is AI 3.0, which is to the right, which are in the past few years, which are these complex models that actually have self-supervised learning from large data sets, able to predict what's coming next in the sequence. And this is largely what we're talking about, and it is the evolution of and the widespread availability of these AI models that have actually introduced the possibility of doing the kind of application of AI to medicine and to public health that we're talking about now. This chart, I think, does a nice job of talking about the challenges and risks, things like hallucination, grounding biases that pervade the implementation of these AI models. I would refer people to a number of resources that are emerging, including the now new journal from JAMA about JAMA plus AI, which actually has a whole range of interesting, I think, papers, data papers, original investigations, but also commentaries around how to think about AI and its implementation in terms of thinking about the health of the public. We did, those not the focus of my talk, this is a paper that actually I wrote with my colleague, Dr. Catherine Ettman, thinking about how one might apply AI to population mental health. Mental health is an area which I've done work on. And the reason I'm showing you this, because I think it's a simpler representation about how to think about the ways in which AI could intersect with the health of the public. And if you look at the bottom base, we talked about how AI could intersect with policies and regulations, then about social context, and then about the delivery of care. So the reason I'm showing you this, rather than dwelling on the particularities of mental health, is to say that I think AI can have impact on the health of the public, both in terms of influencing policy setting, influencing the context in which we live, and then delivery of care. And I think that's actually a useful paradigm for all the applications of AI as we think about the health of the public. Now, what I want to talk about today is about AI in public health. And I'm going to talk about these dimensions that emerge from a paper that I wrote about this with another colleague, Dr. Itai Bavli. And what we're talking about AI in public health is 4 key elements that I think are important to keep in mind. The elements of omission, the element of trade-offs, conflicting inputs, and values, biases, and accountability. And I'm going to just show you a slide for each of these, really just to label these and make these points, and hopefully to have them sort of in the back of all our minds collectively, and then to guide discussion. So I'll start with omission, which is on the top left here. Omission is AI systems that are trained to think about public health and fed comprehensive, diverse data sets need to be genuinely learning on comprehensive and diverse data sets in order to avoid critical omissions and to make to emerge from that hallucinations that do not reflect the world as it is. And it's very easy to imagine a world where the omissions that underpin popular AI models and AI implementation are not only come from neglect and unintentional omission, but also from intentional omission. I mean, tech companies that are behind AI have enormous financial incentive to do things in particular ways. And in no way does this intended to suggest malfeasance or malevolence on anybody's part, but to make it clear that in a universe where we are training models on comprehensive sets of data, what determining whether or not these data are comprehensive or not is it makes a big difference in terms of the outputs that we are getting from AI. So number one, I think one concern is omission, or how comprehensive or not comprehensive are the data sets on which these AI models are being trained learning. Number two is the notion of trade-offs. It is one of the challenges with thinking about AI for the health of the public, thinking about AI for public health, is that AI is guiding us on decision-making that ultimately rests on trade-offs. And these trade-offs are often value trade-offs that are very hard to extract from data. Just to use 2 concrete examples, these are data about the chance of being killed by a car going at different miles per hour. And what you see is to the right is faster miles per hour. If you're hit by a car, let's say you just stick on the 70-year-old line. If you're hit by a car going 40 miles per hour, if you're over 70, you have a 70% chance of being killed. If you're hit by a car going 25 miles per hour and you're over 70, you have about a 20% chance of being killed. That's a 3.5-fold difference. From a pure data-driven point of view, we should be insisting on broad-based reduction of speed limits everywhere. We don't really do that as a society because we're balancing trade-offs. For better or for worse, we are making decisions that actually speed limits being what they are matter to us as a society. I'm not here to litigate whether or not that actually is how it should be or not, simply to say that decisions that affect health are all based on trade-off calculations that reflect values that are not explicit in the data that we are using to provide the comprehensive information set on which AI models arise. To use one other example is in a time of COVID, on the left, it's a graph from the papers that we had written, but it's published in Time, looking at the increase in depression in a time of COVID. On the right shows the increase in drug overdose in the time of COVID. You know, the decisions that we made societally about what to privilege in a time of COVID, whether we wanted to reduce the spread of infectious disease, and whether reducing the spread of infectious disease was worth it in the context of the fact that we're now increasing depression, increasing drug overdose deaths. These are really difficult trade-off questions that, frankly, humans had a very hard time with deriving in a time of COVID, let alone if we're actually training algorithms to try to guide us on this. So number one challenge is omission. Number two challenge is trade-offs. Number three challenge is conflicting inputs. It is very difficult for models to determine the value of conflicting inputs. Here I have two pictures of what I consider health. These are both pictures of health. Picture on the left is the obvious picture of health, which is these gentlemen both smiling and playing soccer. The picture on the right is also a picture of health, people who are healthy enough to willingly throw themselves out of an airplane without a parachute until much further down the plane. The picture on the right would challenge anybody who is not thinking about the purpose of health as being an effort to create space for people to live full, rich lives. And it would be clearly something that would be discounted by any model that is trained to try to maximize health, aka the picture on the left. But they are both purposes of health. So there are conflicting inputs that guide what we might want to do or we might not want to do in health. And these conflicting inputs are very difficult for us humans to even grapple with them, let alone models that are programmed algorithmically. And then the last point, which really underlies all these points, is the point of values, bias, and accountability. And just to talk about these for 2 seconds, I'll talk a little bit about biases. This is a picture of the first year of COVID and the people who did well or didn't do well on COVID on multiple axes. On the top, you have the different colors. They're mental health, personal finances, job security, take-home pay, physical health, etc. If you're below the line, it means you didn't do well in COVID. Above the line, you did do well. And what I want you to see is that the spike of the people who did better on all these dimensions first year of COVID were people with postgraduate degrees, which of course are the same people who program models, who develop models, many of us in this room. And I show this as a very simple example about how biases enter into what we do. If you were actually doing well in the first year of COVID, your mental health, physical health, spending more time at home with your children, you are very likely to see COVID quite differently than if you're somebody who has lower income, who is working in transportation or working in a warehouse where COVID is exposing you to risk all the time. So the data sets and the underlying data on which we all learn all the time. We as humans learn from underlying data all the time. But we're putting a model and learn from the data. The model has no way of discerning the values that inform these data. Another way of thinking about this is the biases about the intersection of the users of these data. This looks at the green is high level of AI awareness and the yellow is low level of AI awareness. And I just highlighted one box. I just want to talk about one, which is education and income. There is an enormous dose response in terms of awareness of AI with income and education. More postgraduate education, more than college, more than some college, more than high school, upper income, more than middle income, more than lower income. So we have these biases that inevitably are going to seep in unless we're very careful, where the underlying context that is shaping how we think about these models, and as a result, the input and data that emerge that might inform health come with a very particular perspective that may end up seeing the world quite differently than the world should be seen in all its fullness. And then one last point about accountability. This is a picture from the White House and the set of COVID briefings that then President and now future President Trump was holding, a picture of the CDC. Because, you know, if one takes these comments that I'm making seriously, if one thinks that they are comments that merit consideration, the question becomes, where's the accountability? Who is responsible for making sure that we are guard these models from some of these challenges. So those are the first sets. Sorry, there's a very loud noise outside my office window. And then I want to end for just the next 2 minutes with will AI widen or narrow health gaps? Because I actually do think that one of the concerns of health is the concern of health gaps and whether or not AI is going to contribute or improve health gaps. And I would like to just offer 2 thoughts on this. Number one is the impact of AI on the foundational drivers of health. And the second one is access to the benefits of AI. You know, I only have 1 slide on each of these. This looks at the drivers of health, the picture on the left, which is well understood by everybody in this room. Health is driven by healthcare, yes, but largely by health behaviors, physical environment, socioeconomic factors, etc. On the right, you have US health and how US health did in time of COVID and how it would have done even absent COVID. US health has lagged behind other high-income countries, largely because of our underinvestment in these foundational determinants. If AI results in a widening of the gap in these foundational determinants, we are going to result in a widening of health gaps. If AI actually serves to bridge our access to foundational determinants, then AI can narrow health gaps. And the last point is the intra and international. You know, we have achieved enormous progress in health across countries. The figure on the left is life expectancy 1941, right? Life expectancy 2021, where now we have really life expectancy in a way that was unimaginable as recently as 60, 70 years ago. But if AI applied to health populations is going to result in widening of health gaps, we are going to see a widening of health gaps and potentially setbacks in the countries with less access to AI. And I think that needs to be part of the AI conversation as we think about AI for the health of the public. I will stop there because I want to stick to 15 minutes as I was asked. This is my last books on the left and my blog where I write some thoughts on these things on the right with QR codes that people can use to access them if people wish. And I look forward to the rest of the conversation. Thank you for having me.
Thank you so much, Dr. Galea. We are going to move now to Dr. Singh for his presentation. And at the end of that presentation, we will entertain questions. So Dr. Singh, are you ready?
Yes, I am. Let me go ahead and share screen. Okay. Obligatory, can you see my screen?
It looks great on my end.
Okay, thanks. So thanks everyone. Really excited to be here. And Sandra, thank you for that great talk. I wanted to talk to you a little bit today about what it means to tackle the health AI paradox. And in this talk, I'm going to do a kind of rewind into computerized medicine, how we got to where we are in terms of health AI, what are the current challenges with health AI when it comes to kind of availability and evidence base for tools. And then I think, what do we need to do in the future to really make sure we kind of tackle that and we advance the science of health AI in kind of an operational and clinical use case. So I want to take you back to the 1960s, where Dr. Warner Slack, who was at University of Wisconsin at the time, had ordered a laboratory instrument computer from MIT and used it to write a program that could take a medical history from patients directly. So this is a system that he wrote, and it was not the first system that could take a medical history, but the first one that could take a history with branching logic. So based on how a patient answered a question, it would pose kind of the appropriate next question using that information. This was all written with punch cards, and here's a screenshot of the New England Journal of Medicine paper from 1966, along with the screenshot of what it looked like to actually use this computer. This is kind of what it looked like. So you would ask it would ask you a question as a patient, and you would answer yes, no, don't understand, or don't know. And although it's not shown on here, I had the pleasure of learning directly from Dr. Slack, and he shared that there was a secret fifth option, which was none of your business. And so, this is, again, directly patient-facing, and patients would go through numerous questions like this. And at the end of it, it would create a printout that had essentially the patient's history and, that could be ingested by a clinician. So how well did this do? At this time, if you look at this table, there were several conditions that were detected both by a physician and by the computer taking a history. There were several conditions that were detected only by the computer, presumably because, physician didn't have the time and bandwidth to sit and ask every possible question. But if you look at the number of conditions that were only detected by the physician, it was none of them. And so this was, again, in the 1960s. And so you can imagine people were not even having personal computers at home. And here comes this technology that can do one aspect of a person's kind of work potentially better than they can. So immediately, this gets published in the England Journal. There's a huge impact. And, I think a day or two later, Dr. Slack interviews with the Wall Street Journal. And the reporter asks him, are physicians going to be replaced by computers? He pauses for a moment, and here's his reply. Any doctor who can be replaced by a computer deserves to be replaced by a computer. And knowing Dr. Slack, I don't think he was arguing for automation. What he was really arguing for here is that there's so many aspects of a doctor's job. Taking a history is a small slice of that. And if really all a doctor is doing that one slice of work, why would you want that person in that role when you could have a computer do that? Now, obviously, clinicians do a lot more than just take a history. And if you look at where we've evolved to today, review of systems is rarely done in the patient's room. It's something that's done ahead of time with technology that probably is not all that different from what Dr. Slack developed in the 1960s. So the story doesn't end there. There are a lot of other advancements that have taken place since then, other systems that have gone beyond just taking a history, but actually giving out medical advice. And on the methodological side of things, both in the field of statistics and in the field of computer science, there have been a number of advancements with the science of using regression for prediction, having a lot of work done on it in the last decade, and several kind of seminal papers on things like sample size calculation for prediction, which previously had only been thought of in terms of inference. And on the computer science side of it, obviously a lot of advancements in deep learning, and that has uncovered and kind of enabled many different things all at once in the fields of predictive AI and generative AI. But despite all this, you would think looking at this, that given all these advancements, we'd be seeing just a ton of models showing, all kinds of really good evidence to supporting clinical work. And yet, where are all those models? Most of the publications we see still are models that are, developed, but not necessarily even fit for purpose. Many of the models in the literature that are developed and are appropriate for that use case are never validated. Many of those are never implemented, and many of those that are actually implemented are never adopted or used. And so ultimately, there's this leaky pipeline where even though there are thousands of papers describing models being built, very few of those models actually are available at the bedside for clinicians to use at that institution, much less any other institution. So you would think if you were only focused on the research side of this equation, that there's just not much AI work happening on the health system side because of this, leaky pipeline that results in this drop of water coming out when we know that there was a lot of stuff upstream in that pipe that never made its way to the end of this pipe. But if you're sitting on the health system side of things, what you're seeing in the background of this is this giant waterfall, this giant flood of models coming. And those are largely not coming from scientific literature and research. They're largely coming from industry. So I think what ends up happening, I describe this phenomenon as kind of the health AI paradox, which is that research models aren't implemented and implemented models aren't researched. And so we have this large, amount of information coming from the research literature that we can never actually use in our EHR because those tools are not available. And similarly, there's this flood of models coming from industry, and we can never actually figure out if they work because very few of those have peer-reviewed literature showing, much less accuracy, even like, clinical benefit of any sort. So here's what it feels like to be on the health system side of things, when I think we are trying to translate what's happening in the research world into healthcare operations and clinical practice, which is that, health systems are overwhelmed by the number of AI models available. For every use case you can think of, there's a dozen startups and established companies with models available in that space. And so I think we were often attracted to the models that were available to us because, that's what we were familiar with. And I think now that the marketplace is pretty saturated, we have to really sit back and look at what are the actual problems we're trying to solve and focus on the problems that are solvable rather than simply what tools are available to us. So when I talk about AI, I really am talking about both predictive AI and generative AI. And I think folks here are, I'm sure, going to be familiar with both of these concepts, but predictive AI, essentially where we're predicting the risk of events or counts. An example would be like the risk of hypoglycemia in the next hour, sepsis, deterioration. Predicting counts might be like predicting the number of units needed for insulin. And largely predictive AI is appropriate when we're trying to allocate resources that are limited in an equitable way. So if you think about it, normally if we had to decide, who's at risk of sepsis or who's at risk of deterioration or hypoglycemia, we might consider all the patient factors individually and try our best to weight those in our minds. And the idea with using predictive AI is that it can learn the associations between individual predictors and that outcome and the risk of having it, such that if we want to allocate our care, like we want to make a phone call or text people who are at risk of having hypoglycemia to make sure they're okay, we do it based on their actual risk of having hypoglycemia rather than other factors which might carry implicit bias. So it's not to say that AI isn't biased, but to say that the goal of using predictive AI is largely to allocate resources in an equitable way. Generative AI, on the other hand, we often focus on what it can do, which is generate text, images, and audio. And when it's generating text, we talk about that as, we refer to it as a large language model. When it's using pictures and text to generate text, we sometimes call those vision language models. But the actual use case of that is usually to extract, summarize information or to answer questions. So I think let's dive a little bit into predictive. We'll dive a little bit into generative, and then I think we'll wrap this up for discussion. So if you look at predictive AI, there is a science to every aspect of the predictive AI kind of life cycle, which is development and evaluation of models, usability of AI workflows. Once you have a model that's actually ready to use in clinical work, you can look at some of the initial first in human kind of interaction of how that's going to figure out if this might work. And then there's the kind of final class of problems, which is implement the AI-based workflow into clinical practice using some kind of intervention and study whether that AI-based workflow linked to an intervention actually works. So I'm just pointing out here that, although people often view these as new problems, they are old enough that each aspect of the predictive health AI lifecycle has a relevant reporting guideline for the scientific literature. For development, it's often Tripod AI. For usability, it's Decide AI. And for reporting on clinical trials, for example, using AI, it's Concert AI. So what are some of the issues with predictive AI that we have to be cognizant of? So some of the work we did in the 2021 was looking at a proprietary sepsis model that was available to us at our institution back when I was at the University of Michigan. And this was the EPIC sepsis model. And at that time, we were being told that the model from the vendor's standpoint was useful to predict sepsis before it happens. So we started piloting it in a couple of units, found that although on paper it looked really good, our frontline nurses and our sepsis team was finding that usually it was flagging people really accurately after the fact, but definitely not predicting sepsis before it happens, at least from their qualitative kind of first in human feedback. So we said, based on that feedback, let's go back and look, can this model actually predict sepsis before it happens? And we found that when you look at whether it can predict sepsis before it happens, the performance of the model is substantially worse than what was being reported by the vendor. If you look at the ability of the model to predict sepsis in the 3 hours after it happens, it does a lot better. And that was largely because, as we later discovered, several of the things that we use to treat sepsis after it's clinically recognized were being used as predictors in this model, namely IV antibiotics. So we went back, we were pretty surprised by this, but we went back and looked at it again and found in another follow-up paper that indeed, if you look at the performance of the model before antibiotics are prescribed, it's no better than guessing, was essentially where it was at that time. So again, that doesn't mean the model is not useful. It does mean that the model is not accurate in predicting sepsis before it happens. And so we need to think about different ways we would use the model if we want to use that model in a clinical workflow. So this was surprising, not necessarily because it was any old sepsis model. It was surprising because it was already implemented at hundreds of health systems. So this was kind of a classic example of widely implemented tools aren't always researched, and health systems don't choose tools based on necessarily the level of evidence they have. They often choose these tools based on ease of implementation. And so this one, because of how easy it was to implement and information that was being given to clients, people felt comfortable implementing it without really any peer-reviewed literature. So we later replicated this work in another health system with 9 hospitals, showing that indeed there's a substantial variability in how well this model performs. And we also identified that, over time, you can see changes in model behavior and alerting patterns. When we had our first wave of COVID, alerts went up substantially for this model, even though it was a model intended for use in bacterial sepsis. So we also published on what do you need to do at a health system level to detect and act on these changes, highlighting the need for AI governance and highlighting a need for frontline clinicians to have a mechanism to give feedback when these things are not working as intended. So ultimately, this led to inclusion of this as a case study in the White House's blueprint for an AI Bill of Rights. And ultimately, it led the FDA to conclude that sepsis and other life-threatening acute conditions are in the scope of FDA regulation when it comes to software as a medical device, and ultimately led the vendor to actually update the model. And so now the model that's live at many institutions for this same model, the next version of it, is essentially an entirely new model. I won't go into this other than just to highlight that we often assume that just because we have a model, we have better information than if we didn't have a model. But there is, mathematical work showing that using a model can be worse than not using a model when you actually ask people how good a model would need to be to not create busy work beyond their kind of tolerance. And so you can easily show for many models, the tolerance is well exceeded when we use the model for how much busy work you would create, so that the benefits that you get from having a highly sensitive model are only realized at a cost that you cannot incur. So that's the kind of maybe, cautionary side of the story, but it highlights the need to be able to measure impact. And I think one of the things that's been exciting in my new role at UC San Diego Health is that we now have some capability because of alignment between our operations and research to be able to layer evaluation clinically related clinical impact on top of research that's happening when the research is aligned with clinical priorities. And so a model that was developed and launched at UC San Diego Health focused on sepsis showed through an observational study, at least, that it results in fewer deaths, something to the tune of approximately 50 fewer patients dying across 2 of our ERs per year than were dying, prior to this model being implemented in a workflow. So that's kind of where I think the predictive AI emphasis needs to shift, is further away from just developing and validating these models, closer to studying more of the impact of whether these models actually work, and some of the work in between of translating those models when they do work on paper and in silico into the actual practice and looking at some of those first in human kind of studies. In the field of generative AI, this is really different from a scientific perspective, because even though most of these tools are developed in industry, they are capturing a large body of knowledge that is general knowledge. So when we apply these into clinical settings, particularly if we fine-tune them in clinical settings, you can actually sometimes get away with a smaller sample size because the models aren't starting from scratch. They're starting with some body of knowledge that doesn't take as many examples to see future data to be able to generate as accurate of predictions. Now, take a lot of that sentence with a grain of salt, because That's at least the promise of generative AI. People are still looking at whether that actually happens. And we found, at least for time series foundation models in generative AI, that assumption does not hold true. But there are likely assumptions where this does. But similarly, a lot of the science you'll read about now is on the development validation side. And very quickly, we will need to pivot to when we think things work to evaluate them in AI-based workflows the same way we would for generative AI. So how does generative AI models work? You start with a prompt. You maybe give it a set of instructions. You give it some patient information to reason about. You run this through the large language model. It generates a bunch of numbers called embeddings. And then you take those embeddings and you convert them back into text. The embeddings that you get out of a prompt and a set of text is always deterministic. It's the same numbers every time. The text that you get is not deterministic because of the way that we go about sampling to convert those numbers back into text. We often teach our frontline clinicians prompt frameworks. So how do you actually use a generative AI model? If you're trying to do some kind of information extraction, you don't just speak to it like you would kind of ChatGPT when you're having fun. You actually need to give it a set of instructions in a certain way to be able to get useful results out of it. And we've been able to take that kind of approach with putting instructions in a certain format, using off-the-shelf large language models, and apply it to quality measurement. And what we found at UC San Diego Health is that we can estimate several questions that we have that we use to measure SEP1 bundle compliance with 97% plus accuracy individually. And if you look at complete agreement across the board of all questions, this is just a sampling of the questions that we look at, we're 90+% accurate. And that's, again, using off-the-shelf tools and tools that are even now considered out of date because there are better off-the-shelf tools available today. But you still have to focus on impact. You can't just stop there. And so we have looked at generative AI to draft patient replies to patient messages. And we did the first randomized quality improvement study looking at whether use of this technology by physicians actually saves time. And at least at a very early stage, when this was very newly integrated into the electronic health record, we found that it might make people's lives easier from a cognitive burden standpoint, although that was informal and wasn't measured in our study, was measured in a sister study from Stanford. It does not save time. And in fact, it increases the amount of time people spend because not only are they reading the patient reply, they're also now reading the AI drafted reply. And it turns out that at least at that stage of the game, that was actually more of a time commitment than just replying to the patient yourself for most of these messages. So again, putting it to the test to see, does it actually work integrated into a clinical workflow? So a lot of our emphasis has been recently on calling for the need for not just AI development and evaluation, but to take some of the principles of implementation science and bring that also into AI, where we use AI implementation science, so is that a clinical effectiveness AI. And many of those things that we're going to do are going to be borrowed directly from the playbook of implementation science in terms of frameworks they use, et cetera. But there are some things that we have to think about when it comes to linking AI into a clinical workflow that maybe is unique to the context of AI and not just something we can take completely off the shelf from an implementation science playbook in terms of what's been developed in that field. There's also a recognition that to be able to do AI-based implementation science, you actually need some level of coordination and alignment between healthcare operations, which decides how you roll things out clinically across a health system, and your research workforce and your research problems that you're solving, because the only way you can do a clinical effectiveness of something that requires tight integration into workflows is usually through that tight coordination. And Chief Health AI Officer may be one way to support that kind of a collaboration between the top down from the leadership level and the bottom up from the researcher standpoint to make sure that the best science happens in the most integrated way possible into healthcare delivery. So to tackle the health AI paradox, I'm situated within the Jacobs Center for Health Innovation, which is within the health system. We're largely focused on tackling this by helping research models get implemented and helping implemented models get researched. And I think the clear thing is we can't do this alone. There's no one scientific discipline that I think owns this issue. It really requires interdisciplinary collaboration. And I think that this is where things are headed in terms of helping us take it to the next phase of seeing the value of healthcare AI. So thank you so much.
Great, thank you so much to both of our presenters. I'm going to start now with facilitating some questions. And I'm not sure if we have any in the room yet, because I'm not sure if I've received any in the chat, but I have gotten a couple over video cast. So if it's okay, I'm going to start with those. So the first question that I have, and I think this is for both of you, given the barriers that we have to access to quality care for many Americans, is it reasonable to expect equity from AI that's trained on electronic health record data when the data are lacking or biased for large groups of people? And are there maybe other types of data that could be used as a complement to help reduce bias?
Go ahead, Dr. Singh.
Yeah, I can go first. So this is a great point. There's a really great paper by Harini Suresh and colleagues that talks about bias in the AI lifecycle. And historical bias is one of them, representation bias is one of them, access to care issues is one of them. And obviously the digital footprint that people have in the electronic health record is highly colored by who has access to care and how their care gets documented within the health system. And that is, I think, not equitable, in many instances. On the other hand, I think that the way to tackle that is to tackle the health equity issues at the health system level. So I don't think you can fix it with technology. You can't fix it with AI. Where I think that AI may have a role is that we have lots of people with low access to care. We have doctor shortages. We have nursing shortages. We don't have the workforce to deliver care to everyone that needs care. And so I think one thing I really think about is can we use it to, can we use AI potentially to help us find people in the community who need care but can't get it? Admittedly, what data source do you use to do that is a big challenge. When I was at University of Michigan, we did a CMMI funded project with the Center for Medicaid, Medicare Innovation, where we linked data from several health systems, including safety net systems, and social work care coordination systems to try to get more of a reach into the homeless population, more of a reach into folks with substance abuse issues. But it's not a data problem. It's actually, you first need to form a learning community around these issues. And then only from that do you build the trust to get the data that you need to build the AI technology. So I think AI is maybe the last line of defense, but it's, as the questioner pointed out, it's not the first, second, or maybe even third line of defense, but it may be a tool in our tool belt that we can use.
Yeah, if I just add to Dr. Singh, I think Dr. Singh's answer is spot on. We are never, going to have all the data that we need in order to actually create the full set of inputs that one would like from a perfect, and I use the word perfect with an italics, AI system. But then again, we never have all the data we need to make decisions as humans. So the imperfect data problem is a universal problem for any decisions that are being made of anything. So I don't see us as needing to get to perfect data. I see us as asymptoting ever better towards data that is less biased, more comprehensive. And I think getting there will take time.
Great, thank you. As we wait for some other questions to come in, I have one myself. So Dr. Galea, I was struck by a statement that you made in that decisions that affect health reflect values that are not explicit in the data that we're using. And so this seems really important to understanding how we make these trade-offs and deciding about the best ways that we address clinical and public health problems. And this seems like this is a place where behavioral and social science approaches can have some really good contributions. So I'm just wondering if you could talk specifically about how maybe we can think about teaming humans with AI to make sure that we're using values appropriately, or how the use of AI is affecting our values, and that we're continuing to use AI in a trustworthy way. Are there specific approaches or research questions you might suggest to get at this a little bit more?
Yeah, I think this is an ineluctable problem with both predictive and generative AI. And once again, I will point out that the values, the implicit values are a problem with all decision making, with all modeling, be it human models, be it simple models, be it complex models. So there's nothing that's new about this as an issue. It is heightened as an issue when we're dealing with models that get more and more sophisticated that the vast majority of us do not understand, because then now all of a sudden you're burying these values within those models. This is why I lumped my fourth category together with values, bias, and accountability, because I think it's an issue of understanding the values, making sure that a prescribed set of values does not unduly predetermine the path, either in predictive models or in generative AI, making sure that there are no large-scale biases that are simply getting us to the wrong place, and then having systems of accountability that vet and create a positive feedback loop around the answers that we are getting and what we're relying on. The other thing that's important to remember is that also, I said that for saying, but this paper, which I know the paper. The other thing to keep in mind is that values and social norms change and evolve. So this is the need for accountability around our bias and around values is always going to be the case for as long as we humans are using any form of machine to algorithmicize decisions that otherwise we would make ourselves.
Thank you. There's Mike Spittle in the audience. We have a question here. So I want to pivot here to people in the audience.
Hi, everyone. My name is Tanisha Dale, and I'm from the University of Miami. I guess I wanted to push a little on the answers that were given in response to, given the fact that AI will be feeding on, per se, medical records or other data, be it from the internet or otherwise, that are already biased. How can we correct for that before it's informing clinical care, especially at a large scale? And the reason I say that we need to think more about this or flesh it out some more is because there has been a tendency, especially among scientists, researchers, to say that if something is scientifically backed, right, you like large numbers, predictive models, then there is rigor and something to believe in, right? And so if we are to utilize AI consistently on a wider scale to help a lot of our issues, where is the point of correcting and checking the bias that will be built into AI because it's feeding on an already systematic and problematic environment as regards to health equity and how we serve people?
Yeah, great follow-up, and thanks for pushing. So I think you made a lot of great points there, and I'll touch on a few of those. So one of them is that data encodes bias. So data encodes bias in two different ways. One way that data encodes bias is through missingness. Another way that data encodes bias is through having information in there that is generated as a result of biases in our healthcare system. And another third way that models or data generates bias is when we're predicting outcomes that are going to be recommending what actions we take. If our current system is biased, that's the biggest concern, right? Where we will reinforce those biases. So pragmatically, I am 100% a believer in what you said, which is large numbers don't solve bias. Just because you have a big sample size just means that you can have a bias at a large scale. And that was shown by Ziad Obermeyer in their paper on dissecting racial bias with a predictive model used by Optum that was guiding recommendations based on ER utilization rather than based on how sick a patient was. So I think the practical things that you can do to try to tackle some of this bias. One is really look at missingness carefully. Missingness is usually a sign of poor access to care. Like something is missing. What was the process by which that data element should have been there? If it was that you needed to have this follow-up or you need to have this thing here, that's usually a key source of bias, not to fill in the missingness, but to understand why you have missingness in your data. The other one, I think, is to really understand how a model links to action, and what does that mean consequentially for folks that you are using that model on. Most health systems now, I think, are starting to realize you can't just turn these things on and assume that they're going to work. Just because you have similar performance measures in subgroups doesn't tell you or protect you from having this kind of downstream negative impact on specific subgroups of people. And so I think that one of the things that we've done is our health AI governance group at our health system, which is in charge of saying, yes, we endorse this use case or not, and we endorse this model or not. We have folks on our committee who are specific experts in health equity. Our chief, our chief executive of health equity is on our committee, as is someone who understands kind of bioethics and AI ethics specifically. So honestly, what I say is numbers can't fix the problem. At the end of the day, there's no performance measure that will tell you this is okay to move forward with. So like ultimately, you have to look at these in a holistic way and come at it with a lot of humility. And honestly, I think the other one is anytime you're using a model that's impacting a specific group of people is to go ahead and engage that group of people to understand their priorities and their concerns. So that's some of the stuff that we've tried to do is through our patient family advisory councils and other places is to get feedback, especially when we are concerned that there may be something that is going to be inequitable. But it's a complex issue. I sit on several national groups looking at this issue with colleagues of mine from around the country. So I'm very sympathetic to what you said, and there's not a math equation that will fix that. It's really a diverse collection of people that you need in a position to be able to make decisions on whether something is equitable or not, and then do the best that you can with the information that you have.
Just one small thing to Dr. Singh's excellent answer, which is Dr. Dale, you were also referring to, well, the underlying data being itself biased or having omissions or embedding a particular set of biases that lead the data itself to be incorrect. Obviously, the no model, and in fact, the more complicated the model, the worse it is in terms of compounding problems in those data. I think Dr. Singh's comments about making sure that the data are emerged from, understood by, and collected in partnership with the populations that they represent is a critical point to help mitigate some of that.
Thank you. We have another question from the audience. And anyone in the audience who have questions, please come on up by the mics here. Thank you.
Hi, my name is Matthew Leitao. I'm actually here at NIH, and I had just a question as you were going through this talk of this kind of difference in valuation of outcome, right? And I see it kind of in this two kind of pronged approach when we're talking about AI is going, hey, when we're normally doing science or doing this research or doing anything in a practical sense, we come from it of we want to understand the phenomenon and the process in which we achieve the outcome, right? So let's just use the sepsis examples we do before. It's like, why is it that this outcome or these measures or whatnot seem to progress in a way to predict whether or not someone has sepsis? Whereas with AI, it may give us a very good answer, but ultimately we may not know what the process is in the first place. And I'm wondering how we're supposed to kind of value this thing of going from the science of understanding to the science of validation between those two things of going, hey, they're both kind of important, but now that the rise of AI, should we be prioritizing one over the other for the purposes of applied outcomes, right?
Yeah, that's a great question. So I think what my answer to that would be that there has been a lot of debate in the field around whether you want to use explainable models, whether that's decision trees or regression models, versus whether you want to use post hoc explanation methods like Shapley values and Lime, particularly in the space of predictive AI. There has been stuff published on both sides of that. People arguing that no, you need explainability because without explainability, you can't really diagnose problems and understand when there are biases encoded because they're not non-obvious. On the flip side of it, there are folks who've said that as you get to better models. Ultimately, to achieve benefit that's equitable, you need the best possible model that's going to give you the most accurate prediction. And so do you really want to sacrifice accuracy in the name of explainability? And there was a great perspective piece by Marzieh Ghassemi from MIT and Andrew Beam at Harvard that talked about, kind of arguing explainability is not really achievable. All these post hoc explanation methods can demonstrably be shown to be wrong through simulation. So when you have a neural network, you can apply these methods, think that you understand what the neural network is doing, but there are ways you can game the data set or game the neural network such that what the model concludes is completely opposite to what you encoded in the neural network, maybe on purpose for simulation purposes. So where I see this right now at is in the world of generative AI, where we're running 70 billion parameter models on our laptop. I kind of think of it as the explainability train, not as entirely left the station, but I think that people are now much more willing to engage with models so large that there's no way they could really ever understand the underlying math happening. But what they gain in exchange for that is now you can directly interface with some of these models and try to use plain English to understand what they're learning. So I think that explainability is important, but I think in the space of predictive AI, I think there is a legitimate debate and balance on to what extent can you explain a model like a transformer model in a way that would be sufficiently appropriate to reach a conclusion about how a given factor affects the actual end result. And I think it's an imperfect science. So I think it really honestly depends on the use case. In some use cases, it is critical to understand the mechanisms. I would say it's not true in all use cases. And maybe the drug analogy is we don't always know why X drug binds Y receptor, but we know that it improves X clinical outcome. And sometimes for certain things, that's enough. Like there's debate around how does Tylenol work or acetaminophen, how does that work? So it's an important debate. I think definitely where there are things like organ allocation, we really need like models that we 100% understand. For predicting sepsis, I think it's great to start with the simpler models, but if the more complex models get us a substantially better prediction, I think it's a trade-off that you have to discuss.
Great. And I think, do we have one last time for a quick question in the room?
Yes, we do.
Great. This will be the last question then. Thanks.
Hi, Brenda Heaton from the University of Utah. Just a high-level question and comment. I am an oral health equity researcher, and so I think a lot about the siloing of healthcare systems. Mental health is another area that's often very siloed. And so what's the role of these AI models in a very siloed healthcare system where not only is care delivery separated, but also the way in which we're documenting care in those settings is very different, leading to a lack of interoperability. So just curious about your comments with AI in a siloed healthcare system.
Well, I can start with that. Thank you, Dr. Heaton. Obviously, I think the issue is far larger than AI, and it is more of a conceptual issue that then trickles down into the organization structure of our healthcare systems. Insofar as adding a new generation of sophisticated tools is an overlay on the underlying structure of the healthcare system, and it's going to build in pathways that are going to be very, very quickly hard to disentangle X years in the future, and that X is not very large. I think the imposition of new approaches is going to entrench polarization that exists already. So my optimistic self would say that as we build in new approaches and new models, essentially it's an opportunity to rethink a little bit how things are structured and to try to impose them in a way that bridges some of what they have been historical barriers. And I'm not optimistic about it, because I actually think there's been quite a bit of thoughtfulness about how to implement AI in various health spaces, and I think it's an opportunity for a refresh.
Thank you. Now it's time for a 10-minute break, and we'll reconvene here at 2:55. And let's thank our speakers. Thank you.
Hi, thanks everyone for joining us. The first session for the festival is leveraging novel technologies and methodologies for advancing behavioral and social sciences research. Our first speaker is Dr. William H. Warren, PhD, Chancellor's Professor of Cognitive and Psychological Sciences at Brown University.
All right, well, thank you very much for the opportunity to be here. I'm starting with a image of a flock of birds, and I'll try to get there before I'm done. Back to why I'm showing you a flock of birds. So for people who are visually impaired, mobility is one of the most challenging activities of daily living, and it often can limit someone's personal independence. People often report particular difficulty walking in dynamic environments, like crowds or busy streets, like this crosswalk in Shibuya Crossing in Tokyo, the world's busiest intersection, but also airports, shopping malls, any places that are congested. So we're asking whether we can build a better assistive device to guide users through a dynamic environment to get to their destination. Okay. Okay, there we go. So I'm working with Professor Benjamin Kimia in the Department of Engineering at Brown, trying to design a assistive navigation device that he calls BlindFind, which integrates a glasses-mounted cameras worn on the head, some onboard computing, and then a vibrotactile belt as an interface to communicate with the user. So the idea is to guide someone around in a complex environment. And we want to try to achieve this with global navigation, that is trying to get localize someone in their environment and plan a route to get to their destination. And also what I'm focusing on, which is local navigation, which is how do you guide locomotion in a dynamic environment that's always moving. In order to do that, we need to understand how vision is used to control locomotion in environments like that. And so we're using virtual reality to study locomotor behavior and to build a pedestrian model that could be used to guide someone around. And that's the kind of basic science aspect of this project. So to do that, we are working in the Virtual Environment Navigation Lab at Brown, a large-scale virtual environment where we can put any participant in a visual virtual environment or a tactile virtual environment. And this is an image of Kevin Rio walking around in the Venn Lab. And our concept is we take kind of a bottom-up approach to understanding locomotor behavior, where we decompose all the complex behaviors people can do into a set of basic behaviors. We study each one of those in VR and model them mathematically. And then ultimately, we try to combine those components to predict trajectories in a more complex environment. So the kind of basic locomotor behaviors we're studying are things like, how does somebody walk to a goal? How do you intercept a moving object? How do you avoid collisions with other moving pedestrians? How do you follow a leader? And the thing I'm going to focus on now is how do you then walk together with a crowd of many people? And that's the current focus of this talk. So walking with a crowd is the problem of collective motion, which is kind of like human flocking. And this gets back to the flock of starlings at the beginning of the first slide. Humans do the same sort of thing, as you can kind of see in this overhead view of Shibuya Crossing. People will walk together en masse in a coordinated movement with hundreds or sometimes more people. So this is often thought of as involving two parts to this problem. First, the rules of engagement. How am I interacting locally with my neighbors in a crowd? And secondly, the neighborhood of interaction. What's the region over which those rules apply as I walk around? So we can think about this. The classical zonal models were derived from animal behavior. So we can think about a bird in the middle of the flock, like this. I can get that to work, I guess not. So the bird in the center of the flock there might be repelled from neighbors in a near zone, the orange zone, aligned with neighbors in the green zone, that sort of intermediate zone, which will generate the collective motion, and then be attracted by neighbors in the far blue zone that keeps the flock together. And so the rules of interaction are kind of cashed out as forces, these sort of metaphorical social forces.
And the neighborhood of interaction in this case are these discrete zones. So that's one way to think about a neighborhood, right? As a metric neighborhood, as most of the classical models assume. So in this case, the pedestrian at the bottom of that diagram is influenced by all neighbors within a fixed radius. And their influence depends on the metric distance of that individual. So that's what makes it a metric neighborhood. Now, one of the things about a metric neighborhood is it's going to depend on the density of the crowd or the density of the flock. So there'll be stronger influences from neighbors in a high density group and weaker influences in a low density group. The main alternative has been what's called a topological neighborhood, where distance no longer matters. And the person at the bottom is influenced by the 7 nearest neighbors, no matter how far away those 7 neighbors might be. And so this kind of neighborhood is going to be independent of density, right? Because it doesn't matter if those 7 neighbors are close to you or far away from you, they have the same amount of influence. And there's some evidence in the starling flocks, like the first slide, that they follow something like a topological neighborhood. Oh, that's controversial. So the third idea that we've been working on is a visual neighborhood. So people don't actually see everybody, right, in a crowd. They can only see a limited view of the people immediately around them. So this would be a kind of visual neighborhood where you're influenced by all the neighbors you can see, and the weights of those neighbors, the influence that they have on you is given by the laws of optics, because things that are closer up have bigger motions than things that are farther away, and by occlusion, right? Near neighbors are occluding farther neighbors, so the far neighbors may have less influence. And we have some evidence in favor of this kind of visual model in some earlier work. And in this case, it also depends on density, but in a different way than the metric model does. So we wanted to, I'm going to talk about is trying to compare these 3 hypotheses of different neighborhoods. And I want to focus on the first 2 at the beginning, and then we'll come back to the visual one. So how do we study this, right? So we developed a virtual crowd paradigm. So we are putting somebody in virtual reality, and we can present a virtual crowd that they can see as they, and they're instructed to kind of walk with the crowd. And as we can figure out which neighbors are influential by perturbing some of the neighbors in the crowd, right? So we make them turn or make them slow down or speed up. And so if we perturb the walking direction of some neighbors, we can see what's the size of the subject's response. Are they actually responding to that particular group of neighbors? And then we measure the subject's walking direction, right? And that's this graph here. It's the time series of the heading direction of the participant who's trying to walk with this virtual crowd. So our data is going to be, where are you heading in the last 2 seconds of this time series? All right, so in the first experiment, we're going to try to pull apart the metric and topological hypotheses, right? And the way we're going to do this is to manipulate the density of the virtual crowd, because that should have predictable effects on each of these models. So if you, in this case, for experiment 1, we perturb random people in the virtual crowd, random avatars, I should say, in the virtual crowd. And the metric prediction is that closer neighbors, because closer neighbors have a greater influence, there should be a density effect, right? The high density crowd, the subjects should have larger responses in the high density crowd than the low density crowd, because the neighbors are closer to the participant. The topological model says there should be no difference because distance doesn't matter, right, for a topological neighborhood. So high and low density should be equivalent. Here's the data from that first experiment. So we're looking at the mean final heading of the participant as a function of the number of neighbors in the number of avatars in the crowd that were perturbed, that changed their direction. And what you can see is there's a larger response in the high density condition than the low density condition. So the solid curves, the blue curve in the high density condition, the solid red curve in the low density condition, shows that we have a significant effect of density with larger responses in the high density than the low density condition. That's exactly what's predicted by the metric model. And contrary to the topological model, those 2 curves should be right on top of each other if it were a topological neighborhood. But the metric model is kind of a poor fit, right? So that low density condition, the dashed line is the model performance, and it's not quite fitting the human data very well. So keep that in mind, we'll come back. The second experiment, we said, okay, well, if the metric neighborhood is really the story, we should be able to reverse that density effect, right? And we might do that now by perturbing the 4 nearest neighbors. We're always going to perturb those same 4 neighbors in the low density and the high density condition, but we're going to manipulate the distance of the unperturbed neighbors, right? So in the high density condition, those unperturbed neighbors will reduce the participant's response because they're not turning. In the low density condition, those unperturbed neighbors are outside the neighborhood, and so the subject will have a larger response to the participants who are actually turning, to the avatars that are actually turning. So the metric prediction now says you're going to have a smaller response in the high density condition than the low density condition. And again, the topological prediction is they should be the same, no difference between the two. And so here's the data. Again, the mean final heading of the participant as a function of the number of avatars that change their direction, that are perturbed. And again, we see we've reversed that density effect. Now the response of the participant in the low density conditions much stronger than in the high density conditions, significantly stronger. Again, contrary to the topological model, but it's as predicted in the direction that's predicted by the metric model, but the fit to the data is even worse than we saw before. So something is wrong here, right? The metric model gets the direction of the prediction right, but it's not really fitting the data. So we wanted to check and make sure that we would see the same sort of density effect in a real crowd. So this is our human swarm experiment where we had groups of 10 to 20 participants wander around the largest room we could get our hands on at ground and stay together as a group while kind of veering randomly left and right. And those antennae are just reflective markers. So we have 15 motion capture cameras around the room. We can track their behavior. So unfortunately, I'm not sure why that other video isn't going, but it's not. So the video on the right should be that you see the traces of the motion capture of the human helmets, and they kind of look like a flock of birds in slow motion. So you can then make measurements on how those neighbors are moving together. So that's what I'm plotting here in this heat map. The heat map represents, the color represents how aligned the neighbors are with the person in the center, okay? So there's a central participant, and we're then aggregating all the positions of all the other neighbors over 5 or 6 minutes of data and computing the difference between the directions that they're walking compared to the person in the center. And so that cold blue region in the middle means the neighbors are tightly aligned with the participant in the middle, 10 to 15 degree differences in heading. And by the time you get to 3 to 4 meters away, they're very loosely aligned, right? Only 45 to 50 degrees difference between them, so much larger. So that's the high density condition. We see strong alignment in the crowd. In the low density condition, it's weaker, right? So the blue is now green, and the areas around the outside, 3 to 4 meters, are red, which means there's less alignment between the central participant and their other neighbors in the crowd. So this is consistent with the metric prediction. We have a density effect again, but it's the opposite of what the topological model predicts, because the neighbors, that region of blue, should spread out through the whole zone if the density doesn't matter. So now we can create a kind of visual model, and I'm not going to bother to try to describe the equation. Don't freak out. So we now have a participant in a crowd where they're only seeing the people that are visible to them. These rules of engagement now are the optical motions of the people that they can see. So they're responding to these optical motions instead of the sort of metaphorical forces. And the neighborhood is defined by the visibility of these neighbors, right? So partially occluded neighbors have a weaker weight than fully visible neighbors. And the neighbors that are farther away have a weaker influence because their optical motions are smaller. So we can take this model and see, first, we want to check, does it in fact generate collective motion? So now we can do multi-agent simulations. Ben Fernandez did simulations of 100 agents running around on a torus in a circle. And these agents each agent is obeying that visual model. So it's responding to the agents around it as the visual model would. And if we let it run, we can see the agents are randomly oriented at the beginning, and within 10 to 15 seconds, they all align and are moving in the same direction. And this time series of heading on the right shows they converge to a common heading direction. So yes, the visual model will generate this kind of collective motion. But now can we go explain our data from the first two experiments? So we go back and now simulate the data with the visual model, which are the dashed curves here. And for experiment 1, the model is much closer to both the high density and low density conditions than we saw before. And in experiment 2, we see that reversal of the density effect. So low is now responding more than high. And again, the model is within the 95% confidence interval of the human data. So it looks like the visual model reproduces the data better than the metric or the topological models. And we didn't fit this model to this particular data set. We fit it to our actually individual people following each other and kept those parameters fixed, and it generalizes to explain this kind of data. So ultimately, we want to implement the model in Ben Kimia's blind find system. So the idea would be that the glasses-mounted cameras now are detecting the motions of the neighbors in the crowd or in the scene. We run those measurements through our pedestrian model to tell the user which way they should turn in order to follow the neighbors in the crowd. We have other models for avoiding collisions with neighbors in the crowd. And then we're currently really working on how to inform the participant about how to walk, right, with these vibrotactile patterns of vibration around their waist. And we're investigating different haptic gestures, ways of encoding information about the world into a tactile vibration pattern. So quickly to conclude, looks like the neighborhood of interaction in human crowds is inconsistent with the topological model. The metric model is a better fit, but it's poor fit, still a poor fit. And the visual model gives us the best fit and can generate the kind of collective motion that we can see. So ultimately, we want to then implement this pedestrian model in an assistive device that would help guide locomotion in dynamic environments. So I want to thank members of the Venn Lab and also my funders, right, the National Eye Institute and the National Science Foundation. So thank you.
Thank you, Dr. Warren. And we have time for questions.
Hi, thank you. Fascinating talk. So you're using a form of agent-based modeling, multi-agent. My question, agent-based modeling has been developing somewhat independently of this new world of AGI and so forth, but it's part of the class, I guess, right? Where do we start adding more stochasticity on the agent-based side, right? More human fidelity to behavior, emotions, whatever. That was kind of the big blocking point 20 years ago, and I'm wondering where we are now. I remember Epstein had written a thing about Agent Zero, and there was this idea of building a real fidelity to the neuroscience I was developing at the time. Anyway, your thoughts. Thank you.
Yeah, so in an agent-based framework, you can simulate a stochastic model as well as a deterministic model. So we're using deterministic equations at this point. But one of the things we want to do is then add some randomness, right, into, you could do that in various ways in a visual model that's trying to replicate, biological behavior. But you could add some noise into the visual end, so there's some error in the detection of the motions of the other agents around you. Or you can add error into the motor end, where your behavior is a little random compared to what the visual input is telling you, or both. And so by doing that, you can kind of test different sources. It's actually a way, the reason I like models is because they allow you to test hypotheses, right? So you can say, okay, I know how this model works, and if I manipulate it to vary some variable to add noise here or there, I can then see what the consequences of that are and compare that to the human data. So I don't think of the model as a final word. It's more like a tool to try to analyze and understand the biological behavior.
I have a question. So I think historically we think of optical models of behavior as sort of being
free of cognition, or at least free of the necessity of cognition. And I'm wondering if there's room in your thinking for modeling, you know, a walker's decision-making.
Yeah, so that's really interesting. We're actually trying to think of the simple decisions like, is the crowd going to turn left or right or split, as a kind of, as a way of, as coming out of the collective dynamics of all these local interactions. So if you set up certain conditions, like, you know, I'm following a crowd and some of the people in the crowd turn right and some of the other people turn left, how do I make that decision? Well, you normally have an explicit decision model, but we're finding that when we do that with our experiments, if the crowd splits by 50 or 60 degrees, there's actually a bifurcation in the collective dynamics of the system. And so the user just kind of based on whatever state they're in at that moment goes with one direction or the other, because it behaves like a mathematical bifurcation. So a little noise will push you in one direction or the other. And so we're thinking that that might be, you know, a first start for understanding the kinds of decisions that are getting made, right? That may not actually be rational decisions, but may fall out of the dynamics of these interactions. And we'll see how far we can push that idea. It's a great question. Sure.
Well, I was also wondering, and I think it's somewhat related, this is beautiful work on people who are navigating crowds effectively. Have you thought about doing this with when it's really not effective, like a stampede or something like that?
Yeah, there's a huge literature on crowd disasters, right? Crushes, stampedes. I mean, there was there are regularly in large gatherings of people, you know, catastrophic failures of this. And so one of the reasons so there are many companies around the world that you can hire if you're building a skyscraper or you're planning, you know, a large event to simulate what the crowd behavior at that event is like. The problem is those are not based on actual biological models. They're based on the kinds of force models that I showed at the beginning, which are not validated against individual human behavior. So you can simulate things, right? And you think you understand the conditions that are going to produce a stampede or a crush, but the individual trajectories don't behave like humans, right? And so I think there's a lot of room for improvement in that kind of simulation study to have an actually human-based model. So that's exactly where we're going.
Great, thank you.
Thank you. Two questions. The
Yeah.
first one is there an end user in mind in terms of like, this technology will help who or what group potentially in terms of navigating motion and environments? And if so, is there input now from end users that may inform how you're thinking about this work? And the other part related to that is going back to what that gentleman asked regarding their other cognitions or pieces that are playing a role. Have you thought about who the crowd is composed of may make a difference for how human beings navigate a crowd, for instance? If it's after a game and I'm the only girl in the crowd and the majority of the crowd are not women, I likely won't diverge when they go right? I may stay on the main with them. So how are you thinking about those pieces?
Yeah, great questions. So the end user in the case that I was talking about at the beginning it would be an individual with a visual impairment of some kind, low vision or blind user, who at the moment has the long cane, very robust guidance device, but only works over less than a meter and misses a lot of higher level obstacles, for example, and then doesn't work at that sort of intermediate range. There have been a bunch of attempts to devise assistive devices that users just reject, right? Because either they're just too hard to use, they have whistles and buzzes that are going off all the time. It's very distracting. So there's some really interesting user studies that show the limitations of some of those previous attempts at assistive devices. So something like the haptic belt, I think, is attractive because it's inconspicuous. The technology is getting there, so you could actually have an inconspicuous, glasses-wearing device that would be relatively easy to use. And so Ben Kimia, who's developing the technology, is working with a user group of blind people who have experimented with these other kinds of devices, and he's getting a lot of input from them. And there's a group that I'm interacting with in Spain who's also done user studies to try to get input on this from actual users. So I think it's very important to actually come up with a device that people are going to want to use, right? And will be as easy to use as the long cane. So that's one end user. Other end users are exactly the sorts of pedestrian and crowd planning and disaster management sorts of situations that Sherry just mentioned. And I think that, and we've done actually some also behavioral studies on people, fire alarm goes off and how do you make a decision about how to move? Do the people moving around you influence your behavior? And the answer is yes to that, although it can be in somewhat complex ways. So two potential end user groups for this work. The second question was, what was the second question? Oh, yes, great question. Yeah, there's actually increasing work on what are known as heterogeneous crowds, right? So people who walk slower or faster have age differences, size differences, gender differences, right? And how is that going to affect things like responses to a fire alarm? And so my basic approach is to try to develop a generic model that then we can adapt by changing the parameters on the individual agents to say someone who's walking slower or walking faster, someone who's got an identity, right? And now we have to introduce, well, how are other people reacting to each other's identities? We're not there yet, but that would be more of a kind of a cognitive addition to a model like this. But we can do things like manipulate the speed of motion or the wanderingness of motion and look at the results, to do experiments and then do results, compare those to simulation. So that's doable. I would like to get there. There's so many experiments.
Thank you, Dr. Warren. Our next speaker, Dr. Nagar Fani, Associate Professor at Emory University.
Hello, can you all hear me okay? It's such a pleasure to be here. I want to say a big thanks to the wonderful folks at NCCIH who invited me to be here. And it's extra special to be talking to you all today about a device that also uses vibration to help people with their stress at a time that I think we're all feeling quite a lot of stress. So I'll be talking to you all today about a device that works with breath-focused mindfulness to help take a load off of the brain, reduce stress, and help people with their overall health. And the motivation for this work has been through my work with a very stressed population. So over the past 17 years, I've been working as part of the Grady Trauma Project. This is the longest running study of psychological trauma in the nation. People in the Grady Trauma Project have been historically recruited from Grady Memorial Hospital, which is a publicly funded hospital in downtown Atlanta. This is a study that was originally designed to look at risk and resilience factors for post-traumatic stress disorder. And people in this study have been recruited on the basis of just being in the waiting rooms of primary care clinics, waiting for their appointments. They were randomly recruited into the study, and we were asking them questions about their overall life experiences, including psychological trauma. So people in Grady Trauma Project, we've been collecting data over nearly 20 years, mostly are Black, mostly women, 18 to 65 years old. And we have data over 12,000 people, it's much more than that now. But just to give you a sense of the demographics of our population, so many of the folks who come through our studies have experienced more than one psychological trauma, on average 4 different types. And you can see with this graph that physical assault with or without a weapon is very prevalent among our participants. We can also see disproportionately higher rates of psychopathology like post-traumatic stress disorder, both currently, which you see in gold, or in the lifetime in blue. Nearly half of our participants endorse symptoms that are consistent with a diagnosis of post-traumatic stress disorder sometime in their lifetime. Major depressive disorder, similar rates. You can also see that other types of stressors are prevalent in our population. So nearly 64% of folks coming through the study report monthly household incomes of $1,000 or less. So this sort of echoes the overall stress burden that people carry. Furthermore, when you look at stress-related health problems, those rates are rather high in our population as well. So we do history and physical exams and find out that problems like hypertension, dyslipidemia, diabetes, asthma are very prevalent. Over half of our folks have hypertension. This is really striking, but is actually a very clear reflection of the health disparities that are apparent across the United States. Dr. Simoni really brought attention to these data earlier, so I don't need to repeat it, but I will say that overall health disparities for Black versus white populations is very stark, especially when you look at neurological brain health problems. So Black people, as compared to white, have a much higher rate of developing dementia, Alzheimer's dementia in particular. When they do have dementia, the functional impairment from these problems is much higher. When they have strokes, it's more likely to cause death. So this has brought a lot of attention to me about what are some of the factors that are contributing to these health disparities and what can we do about it. I've talked to you all about stress, the stress of not being able to pay your bills, of psychological trauma exposure. We also study the stress of experiencing racial trauma in the form of racial discrimination, and this has been at the heart of my work as well. We ask people about different types of discriminatory experiences they've had in their lifetime across medical settings, school, work, et cetera. And what we found is that these types of stressful events tend to activate areas of the brain that are involved with vigilance. So you can see temporal regions, visual attention regions. Our work is showing that people who've had more stress in the form of racial discrimination have more of this vigilant type of response. We also see the default mode network light up more frequently as people may be thinking about, ruminating about racist experiences that they've had. We also see more emotional internalization, so rumination and suppression of emotion. So people may be suppressing their emotional responses to these stressors. And over time, these burdens of being more vigilant for threat, of ruminating about experiences or suppressing emotional responses, they play a burden on the brain. And over time, this burden of these functional coping adaptations to stress, they have an impact. So what we can see with our own body of work as well as the work of others is that there's a measurable physical response in the brain, so that there's a brain atrophy that we can see on a gray matter and white matter level. We see cortical thinning, particularly in prefrontal cortical areas of the brain. We see white matter degradation, particularly in prefrontal regulatory areas of the brain. The findings are really striking, and many findings are specific to racial discrimination. So clearly, the stress of all these burdens is taking an effect that may be making the brain more vulnerable to these brain health problems down the line. Another coping adaptation to stress is dissociation. Dissociation is a kind of way of escaping from a stressor when you can't really escape physically. So it's about disconnecting from your body or disconnecting from your surroundings. And we all engage in dissociation at some point in our lives, and maybe some of us more than others right now. But what we can see is that dissociation is a common coping strategy among people who are coming through the Grady Trauma Project. So nearly half of our participants endorse clinically significant dissociation. And we can see that people who've had more experiences of racial trauma, racial stressors like racial discrimination, they tend to depersonalize or detach from their bodies. And this disconnection from the self, from the surroundings, naturally has an effect on attention. So it's hard to focus on a single thing when you're disconnecting from your current experience. And that's something that we can see on both a behavioral and a brain level. So we've looked in the Grady Trauma Project at people who are high dissociators versus low dissociators, and we've given them tasks inside of the brain scanner, like this affective Stroop paradigm that you can see here, which requires people to regulate their responses to emotionally evocative stimuli, including trauma-relevant stimuli, as they do a neutral cognitive task. What you can see in the graph at the bottom is that those who are more dissociative tend to make more errors on this task when they're confronted with trauma-related reminders. Further, we see not only these disruptions in attention, but we can see disruptions in pathways that are involved with interoception, or the ability to register, connect, process the signals that are coming from the viscera. So when you're feeling cold, when you're feeling hunger, those kinds of sensations are registered in a part of the brain called the amygdala, the insula. The insula is really central to our ability to detect, interpret, and process these kinds of visceral signals and integrate them with our emotional experience. We can see that highly dissociative folks coming through the Grady Trauma Project have a disconnectivity between the amygdala, which is central to the processing of emotion, and the insula. Further, we know that racial discrimination plays a role in the neural adaptations to racial stress, and this may have an effect on dissociation. So one of my students, Aziz El-Bashir, has looked at how racial discrimination affects the brain and how this affects behavior. What he found was that people who've had more racial discrimination show a disconnectivity between the insula as well as the prefrontal cortex, all those areas that you see in blue. And this disconnectivity is associated with disconnection from the self and the surroundings. So as there was lesser connectivity in this interoceptive pathway, there was more symptoms of dissociation. So I've told you all a very difficult story about how different types of stressors, including discrimination, have an effect on the brain and put a load on the brain. Now I want to talk to you about how we can take the load off, reduce effort, and reconnect with the body. And as a clinician, I'm a clinical psychologist. I've thought a lot about sort of interventions and treatments that are designed to focus attention back to the body. Mindfulness is something that has come to mind. Mindfulness-based practices, including breath-focused mindfulness, are really designed to redirect attention back to a single sensory cue, like the breath. So what we can see with neuroimaging studies of mindfulness, we can see that areas like the insula and the prefrontal cortex come online with people who tend to meditate more frequently, more experienced practitioners. We can also see that mindfulness-based practices can be particularly useful for minoritized populations. So mindfulness isn't just about bringing in sensory awareness to something like the breath, but it's also about validating one's emotional experience. And it may be a combination of both that has led to a lot of researchers suggesting that mindfulness may be particularly useful for minoritized, including Black populations. But for many of us who have tried mindfulness, we know how difficult it can be. So think about if you have a particularly hard time connecting with your body, doing something like focusing on your breath may be a really hard task. So if you're a dissociator, you can barely sort of register signals like the breath. And if you're doing something like you're trying to focus on your breathing over and over, trying to get to sleep, it's the election night. This is definitely not a situation that I've experienced. This is a really hard thing to do and stick with. And it requires a sustained effort that is really hard. And this is something that I really struggled with is, you know, this seems to be a practice that is well suited for highly dissociative stress populations, but it's incredibly hard to engage in. So myself and a colleague over at the University of Pittsburgh, Dr. Greg Siegel, have been thinking about how do we make it easier for people to connect with their bodies that doesn't require the sustained cognitive effort. And this is what we came up with. So what you can see on our model Daniel here is our device that when Daniel is breathing, this device detects his breath through the respiration belt and delivers the breath as a signal of vibration that's proportionate to the breath via a wearable subwoofer that's on his sternum. So each time that Daniel breathes, he feels his breath as a vibration. And with this, we are thinking that we can take something that is a bottom-up, sensory-driven kind of pathway to help people engage with their breath and these body signals in a way that can be effective. So taking this pathway from the mechanoreceptors in the sternum, going through the spinothalamic pathway into the brainstem, the thalamus, and then those upper level cortical regions, the insula, and then the prefrontal cortex, we may be able to hack these systems and help people engage in breath-focused mindfulness in a way that doesn't require so much effort. So boosting body awareness and helping people enhance their attention to the breath, enhancing interoception. So this has been the impetus behind our work. And about 8 years ago, we started doing some pilot testing where we had people come in and do breath-focused mindfulness, 20-minute sessions, really brief. And they had 6 sessions. And what we did was we assigned them to a breath-focused meditation versus vibration-assisted breath-focused mindfulness. And we did some imaging pre and post in a subset of individuals. We also did some physiological assessment, cognitive assessment. And these are the data. So what we found was that people who were getting the vibration during breath focused mindfulness, those are the folks that you see in red, reported greater interoceptive awareness, particularly body trusting. So it's not enough to be able to detect your body sensations, but you need to be able to trust in them and see them as a reliable source of information. And that's what we were able to see when we were adding the vibration. We saw this increase in body trusting in particular. We also found that improvements in interoception corresponded with changes in dissociation. So as people were better able to both detect their body signals and trust them, you could see that their dissociative symptoms went down. So people in red, again, were the vibration augmented breath focus. The blue were breath focused mindfulness without the augmentation. We could also see through physiology that those who were getting the vibration showed changes in interoception that corresponded with changes in heart rate variability. So people who were getting the vibration tended to have greater increases in heart rate variability, which is a measure of autonomic flexibility. So how well your body is adapting to changing circumstances. Heart rate variability has been connected to many positive physical and mental health metrics, and this was really encouraging for us to see. Finally, we were able to see increased connectivity in interoceptive brain networks as well in people who are getting the vibration augmented breath focus as compared to breath focused mindfulness in general. So this was promising pilot data that led to our current multi-site clinical trial over at Emory and the University of Pittsburgh, where we now have a 2x2 design, breath focus versus no breath focus, vibration versus no vibration, doing a lot of measures. In addition to what you can see, we've been looking at not only neuroimaging, but some physiology and EEG. So we're looking at EEG from session to session. We're also taking blood to look at inflammatory markers. And I'm going to show you some really cool preliminary data that we've gotten so far. So when we look at session by session metrics of what people say about how they felt and how they rate their body experiences, we can see that overall people's ability to sense their body signals improved over time. That was for everyone. But the people who were getting vibration, either breath synced or not, even in the first session, we could see that that problem was significantly less and stayed less than the other group. We can see also that this is work that my postdoc, Dr. Tim McDermott, has done, that there are some changes in autonomic regulation in the breath sync vibration. So people who were getting the vibration augmented breath focused, again in red, as compared to the other groups, had lesser breath rate variability. So this isn't just about the breath rate, but how variable the breath is from breath to breath. And why is breath rate variability important? Well, this is kind of an understudied metric of autonomic regulation. What we found is that people who had less breath rate variability, so we looked at these emotion measures, we saw that less respiration variability corresponded with less negative emotion. So it could be that those people who are engaging in the breath focused mindfulness and getting this breath augmentation may be breathing more regularly and possibly were more engaged in the intervention. And we do a lot of data analysis. We've looked at things like qualitative data feedback. So we ask people about their experiences outside of the sessions and code them thematically. And what we're able to see with the red line, again, with vibration augmented breath focus, is that there are changes outside of the lab, that people are reporting greater body awareness from session to session as compared to the other types of conditions. We see a high rate of retention in the study overall. So from pre to post intervention, study attrition is very low, but those who are getting the vibration augmented breath focus have the highest rates of retention at 98%. And that is both at the acute phase and the follow-up at 6 months. So all of these data are really interesting. I don't think I have the time to show this clip. The show, Your Fantastic Mind, featured some of our work on their PBS show. Please check it out. It's on my website, which is just my name.
This is how I think about it.
And that talks about our individual participants' experiences in the study. I want to say that this is work that we bring into the community as well. So we want to know how people in the community receive this type of intervention. And we also go into the community to talk about what mental health coping strategies they have, what is useful, and how we can bring things like mindfulness into the community that will be acceptable. So at least once or twice a month, my group goes into the community to talk about this type of work. I'm also working with a group at Georgia Tech to help develop this device into something that people can buy at Target or Best Buy, and that would be low cost. So $150 would be the max. We're trying to work on this device so that people can use this, not just in the lab, but in their day-to-day lives, and not have to come to see a specialized provider like myself, something that most people don't have access to. And you know, all of this work is really done to say that I think that we need to be focusing on interventions that are using some sort of exteroceptive technology to help people connect with their bodies, feel a greater sense of stress relief that doesn't add more cognitive burden. So not relying on interventions that really ask people to put more on their brains, but adding things that sort of take the weight off of the brain. There are other people who have similar ways of approaching this. So Dr. Doug Bremner, who's also at Emory, is doing transcutaneous vagal nerve stimulation in people with post-traumatic stress disorder. And this is producing big results, not only with symptoms, but with inflammation. There are other types of augmenting technologies that I think can be really useful, like the temporal interference brain stimulation that myself and a colleague, Dr. Treadway at Emory, are pursuing. This is a non-invasive brain stimulation technique that we can use to augment things like mindfulness to help people engage, and also is low cost. I think I am out of time, but I wanted to say that this work is thanks to both the time and effort that our participants give to us and the trust that they give to us to be part of this research, the labor of love that is performed by my team every day. And I want to especially thank NIH and NCCIH for funding this work. And thank you all for listening.
Thank you, Dr. Fani. And now we have time for some questions.
Thank you. What is your thinking about interacting with self-medication? People coming in with, they're already using drugs, and mindfulness, how does that interact with pharmacological or non-pharmacological self-medicated populations? So
I think when you think about different types of treatments for stress and trauma, I think mindfulness might have the least negative interactions. So I think a majority of people coming through our study are cannabis users to some degree. We exclude people who are severe cannabis use disorder folks, but this is very common in our population. And what I have noticed is that there is a lesser reliance on self-medication through recreational substances and a greater ability to engage in mindfulness even without the device in our participants. So it's like, for many folks, they report a kind of sensory trace of the vibration that they're able to carry with them and use as a source of stress relief. Just last Friday, I was talking to a participant who said, I got it. When I was really getting upset at the store, I told myself, go into your place and think of the vibration. And she was able to get through this situation without exploding, which was kind of her norm. And we do not instruct people to change their medications, and we do not talk about, substance use, using less or more. But we have heard anecdotally that people are changing their use patterns over time, and some people have actually reduced their use of like benzodiazepines as a way to cope with stress. It has been really informative to talk to our participants and hear their stories, but I think a lot of positive things.
That was fascinating. This strikes me as a kind of biofeedback technique, right? And I wondered if I know there was a lot of interest in alpha many years ago as a biofeedback technique to achieve similar sorts of ends. And I wonder if you've compared this with other forms of biofeedback.
Yeah, I have. And the difference is that we're not asking people to train to do a particular thing, to reduce a response or anything like that. We're simply using people's biological signals And so that I think is a big difference between us and like the neurofeedback and biofeedback. We're not asking people to bring anything down or up. But we are seeing that people are, as they attend to their breath, they do seem to want to change their breathing in such a way so that they get more of the vibration. And I think this is sort of borne out in the respiratory variability data. When we're seeing more regular breathing over time, it's possible that they're sort of finding a rhythm and regulating themselves. And it's a very personalized rhythm. So it's not something that we're asking them to do, but I think is naturally occurring.
So you just mentioned attention, and I was wondering, is attention what's gluing the link between the mindfulness and the interception?
I think I didn't emphasize enough that the study that we're doing right now is a mechanistic clinical trial with the two mechanisms being attention and interoception. And so as an attention researcher, you know, my thought coming into all of this was like, this is all about attention. But I think it's actually more than attention. It's a sort of intersection of attention and interoception. And I think about finding this regulatory rhythm, like a personalized regulatory rhythm. So I think it does seem to enhance attention. But is that the pathway through which, you know, all these other benefits occur? Or is it the ability to trust body signals? Is it about people's ability to detect and trust that their body is a safe place and then use that information to regulate themselves? It's hard to say which one is first. Yeah.
I can ask. Yeah. So I've been diagnosed with both PTSD and bipolar disorder. So there are times like when I get manias and go through lows, and it has also affected my like focus, learning, and attention, like because of multiple hospitalization in the past. So I'm trying to ask you, how does this device help me during those times where I have difficulties like through my disease?
I didn't catch what the
How will this help like a PTSD patient, PTSD and bipolar patient like me when I'm going through highs and lows, and also when I'm recurring my trauma, like if I'm whether I'm journaling that, like trying to process through it, because I learned like journaling can help you, but it also comes back to recalling those events in the past, like a natural disaster, things like that.
Right. So obviously this is not a trauma-focused intervention where, you know, people are coming and talking about their trauma experiences. But I think that one possible way it can help a lot of trauma survivors, which are the folks that we are working with, is that there is a greater ability to sit with and have exposure to trauma memories and thoughts and emotions in a way that can be therapeutic for folks. So we do not provide any kind of talk therapy in the lab. But we have heard from folks that when they have time to do this intervention, things come up about the past, and a lot of negative thoughts, emotions, and maybe you know, negative cognitions come about. And I think that the ability to sit with, process these events in a way that feels safe, that could be one mechanism. Like it is, I think, a kind of exposure therapy of sorts. But I think another way is simply by reducing arousal. I think, you know, this increased physiological arousal is characteristic of post-traumatic stress disorder. And if people can put this thing on and help them reduce their level of arousal, they may be able to grab onto other interventions like prolonged exposure therapy or engage more fully. So we think about it as a potential monotherapy or an augmentative aid. So for those who are going through prolonged exposure therapy, they could use this to sort of reduce their levels of arousal to better engage in those kinds of interventions.
Thank you.
Thank you, Dr. Fong.
Thank you.
Our next speaker is Dr. Brenda Heaton. Associate Dean for Research at the School of Dentistry and Associate Professor at the University of Utah.
All right, we're going to zoom out from those prior two presentations, which were wonderful, and look at the population, look at things more on a population level. I just want to acknowledge my multiple identities right now. A lot of the work that I'm going to be talking about was done during my time at Boston University and is still being done there after my recent move to the University of Utah. So what is homophily? This might be a term that many of you have not heard yet if you're not working in the social science, social network spaces. I'm an epidemiologist, and in a lot of epidemiology and biostatistics, the methods that we deploy to understand health and disease on a population level have this automatic assumption of independence. And that underlies all of the most of the statistics that we engage in. But when we're talking about behaviors and particularly social behaviors, we're actually operating in this realm of interdependence. And interdependence is this idea that individuals in a population are actually connected to one another in informative ways. And when we think about that interdependence, what homophily is this idea that we're preferentially selecting people who are like us. And it's causing this sort of clustering in our social circles that creates some sameness. So it's this idea that we're selecting others who are similar to ourselves. And this has primarily been studied on the basis of social demographic variables, age, gender, race, ethnicity, social class, or occupation. And there are two hypotheses or lines of reasoning for why do we develop homophily in our social networks. And the first is this similarity attraction hypothesis. It's this idea that homophily reduces the friction or the psychological discomfort that can come from differences between ourselves and those who are around us. And so we tend to try to avoid that and reduce the potential areas of conflict in our relationships. The other is this theory of self-categorization, where individuals define their social identity through a process of self-categorization. So when we classify ourselves as, based on age, race, gender, and we find those around us to be similar, it kind of legitimizes our social identity. And so we self-categorized in order to legitimize our sense of self. So social network homophily, it really has important implications for the success of interventions that aim to moderate behavior. In fact, this work was born out of a behavioral intervention that was done on an individual level that basically failed. We were trying to use motivational interviewing with caregivers to reduce their oral health risk factors for their kids and the development of childhood caries. There's a lot of research that shows the importance of homophily in the success of interventions. So Centola looked at subjects who observed adoption by somebody else, who they understood to be similar to themselves along gender and body mass index. They were more likely to adopt the behavior themselves. And Centola explains that this is likely because the signals from this homophilous relationship were perceived as more relevant. Their behavior was perceived as more relevant. There's also work by Flatt that discussion groups, people who we talk to about important matters or personal problems, that any information that comes from those groups, it's perceived as more credible. And they're more likely to act on that received advice if they perceived the people that they were engaging with or discussing those matters with as similar to themselves. And that has implications in all sorts of areas of health. And we can think about that even in terms of healthcare delivery as well. And so ultimately, this idea of homophily shows that when there's homophily in social networks, that the spread of information, behaviors, and resources is accelerated. In fact, we can even look at behavior and homophily and behavior as a contagion. And as I mentioned, homophily has really been studied mostly along sociodemographic lines. The incidence of health-related homophily hasn't really been well documented. And this is what drove the paper that I was asked to discuss today, which is health-based homophily in public housing. Public housing developments, government-funded housing, are a really interesting population to look at social influence in. The selection mechanisms into public housing, they already create homogeneity in terms of social demographics that are often associated with health and health behaviors. So residents of public housing bear some of the highest burdens of chronic disease in the country. And they're much higher than their socio-demographic counterparts who are not living in public housing. So this is an interesting population to work with in terms of health-based homophily. And we asked the question, to what extent are adult ego networks homophilous along key health concerns? So could we identify the presence of homophily in these social networks? We worked with our partner, the Boston Housing Authority, to look at a few public housing developments, and we enrolled ego networks from about 120 adults. And when I say ego is the person that we are interviewing, and we are asking them to report on the people that they talked to about important matters, the people that they were sharing meals with, who were they going grocery shopping with, and who were their local contacts in the public housing developments. And those named social ties we refer to as alters. And we looked at this using a multi-level model in which ego networks are nested inside of these egos. And I've just created a simplified model equation to not scare you. And we have here, oh, that's not working. On the left-hand side of the model, we have the alter. And so we're looking at these social ties as the dependent variable, and we're trying to understand what's the likelihood that somebody perceives their social contact to be similar to themselves. And that's a function of their own characteristics, the characteristics of the other person, and the nature of the relationship between the ego and the alter. And what we find is that in terms of oral health, the odds of an ego reporting their social contact, the alter, as the same as themselves, so the odds of reporting their oral health as fair or poor were 5 times larger if the ego themselves also perceived their oral health as being fair or poor. And what's interesting about this finding is that it was completely independent of any social demographic variables, as well as the attributes of the relationship itself, showing that perhaps oral health may be a network generating mechanism, that people are extending and receiving ties based on their oral health status, which if we consider the separation of medicine and dentistry, people need that in order to navigate the oral healthcare system. We saw homophily along overall health, but it was not as strong. And we also saw it in terms of the perception of weight. We looked at sugary food consumption and sugary sweetened beverage consumption as well to identify if there was homophily present on these common chronic disease risk factors. And we found that the odds of daily consumption of sugar sweetened beverages were 3 times as likely if the ego themselves were also daily consumers. And we see it similarly for sugar sweetened foods. Interestingly, the homophily did matter in terms of the nature of those ties. So if the individual that they were connected with were individuals that they connected with for multiple reasons, meaning they were multiplex ties, specifically individuals that they shared meals with and individuals that they grocery shopped, they were more likely to be homophilous along sugar sweetened beverages and sugary foods. And also education seemed to play a role in the homophily on these common chronic disease risk factors as well. So if they were homophilous on education. They were also homophilous on these consumption patterns. And we can see it if we actually map the network. You can see that this is a social, that consumption behavior is a socially clustered phenomenon. So in the blue here, we have daily consumers of sugary foods, and the red is non-daily consumers. And you can see how they actually cluster when we look at the network maps, again, for sugar sweetened beverages. So when we look at the interclass correlation coefficient, it shows us that as much as 40% of the variance in the total variance in the alter's health and consumption patterns is attributable to that connectivity with the ego, mandating that we really look at the interdependence when we're talking about these sort of social behaviors. And also, we've just general finding is that networks are strongly homophilous on oral health, sugar sweetened beverages, and sugary foods. And these dietary causes of poor oral health are extremely important. And the poor oral health and risk behaviors naturally tend to cluster among the adults in this dense low-income housing space. So once we were able to define that homophily existed, and that there was homophily on these important health indicators in these networks, we then are asking the question, well, what are the relational and individual level determinants of health-based homophily? And this will allow us to design network level interventions so that we can increase the effectiveness of interventions to modify behavior. And so before, where we were looking at the alter as the dependent variable, we're now looking at the ego alter homophily and trying to predict homophily on these topics with the data. So we went back to the public housing developments and we enrolled people from a couple of housing developments. This time we looked at close to 300 adult ego networks and nearly 1,000 ego alter ties. Again, asking them to name people who they talked to about important matters, meal sharing, and people that they were close to in the public housing development. And now we can see that the nature of the relationship makes a difference in whether or not the egos perceive their alters as being the same as them. And so we found strong associations between the frequency of shared meals and the frequency of daily contact in predicting the homophily on oral health. So oral health homophily was common when people were engaging regularly over meals and just in general. Smoking status reduced the likelihood of homophily. Or smoking is something that's very predictive, a huge risk factor for poor oral health. And so if people had ever smoked, that led to more heterophilous relationships in terms of oral health. Whereas if an ego perceives themselves to have excellent, very good, or good oral health, they were 32 times as likely to be homophilous on oral health. So interventions in the context of oral health, if we have interventions that center on meal sharing, it may present an opportunity to improve upon individual level interventions that target oral health. And better oral health also tends to cluster within social networks in which the ego is reported to have excellent to good oral health. And this implies that these individuals may benefit from an added layer of social advantage beyond those who are in poor oral health, which may mean that social dynamics are really an important contributor to the occurrence of oral health disparities. Even in these public housing developments where we have a preponderance of poor oral health, the way that people are self-categorizing and self-selecting their social networks, those who are in self-perceived to be in excellent, very good, or good oral health are connecting just with one another, which reduces the exposure to those individuals by people who are in poor oral health and then have less influence from those who are in better oral health. So we also see that the nature of the relationship matters for consumption of sugar sweetened beverages and food consumption, with frequency of contact being a key indicator of homophily on sugar sweetened beverage consumption. We continue to see this role of education homophily. And we also see that if people are homophilous on sugary foods, they're much more likely to be homophilous on sugary beverage consumption. And with food, again, we see that its frequency of contact, education matters. And again, if you're homophilous on sugar sweetened beverages, you're also homophilous on sugary foods. So what does this mean? Well, it means that the frequency of contact and shared education levels, they're primary predictors of consumption homophily for sugary beverages and sugary foods. And it also implies that they tend to be clustered regardless of consumption, frequency. And that means that they're producing segregated populations. And this can actually be detrimental to interventions because people who are high consumers don't have access to people who are low consumers because they're completely segregated populations. So you're losing that social influence that can occur through homophily, and it can heighten the risk for high-level consumers because of that limited exposure. And it also, the finding also implies that this idea of homophily is a layered phenomenon in that beverage consumption is predictive of homophily on food consumption and vice versa. And so any interventions would need to target these behaviors jointly. So when we look at social networks and we look at the attributes of how people are self-categorizing and self-selecting their contacts, we get a wealth of information about what the dynamics are that are occurring on a population level that allow us to have better information to go about designing multi-level interventions and making sure that intervention is sustainable over time because it's reinforced through the social network. I just want to acknowledge the communities of Boston Public Housing that have been contributing to this work over a number of years. I also want to acknowledge my co-author on the paper, Dr. Neha Gondal, a sociologist and expert in social network analysis, my Boston University team, and funding that was received through the National Institute of Dental and Craniofacial Research, particularly through OPNET and OBSSR. So thank you.
Thank you so much, Dr. Heaton. Questions?
Thanks, Clay. Thank you, Brenda. Smoking came up as an important characteristic in this population. And that, to quote you right, segregates those people and has an impact on homophily. Is there a either HUD-based or Boston Public Housing organizational policy on where tobacco can be consumed on public housing property?
Yes, several years ago, HUD rolled out a smoking cessation program for public housing residents where they were not allowed to smoke in residence. And the basis of that was really around fires and preventing fires in those spaces. And so there have been studies done in Boston Public Housing that show that they're hiding the smoking behavior. And then they're smoking more in communities, and it becomes even more of a social behavior because they're doing it outside where they can congregate with others. So there's actually some really interesting network phenomenons associated with those smoking policies in the housing developments because it's almost reinforced the social nature of it. And it helps to create more segregated populations with respect to that behavior. Does that answer your question?
It does, and I think it's something to consider for future opportunities. Thanks very much.
Yeah.
Thank you. That was a great presentation.
when you enrich the insight with the sociological idea that homophily sits in a context, you beg the question, which other social scientists have found, when people are with preferred folks, what's the motivation to shop at Whole Foods when you've been going to Burger King every day, right? Like you did, that's so foreign, it's so different. And so what are you thinking about, since you've expanded it from connectivity to, well, there might be a class or a residential segregation thing going on, what's the purchase point? I thought as you were talking, you were focusing on the people and the social, but it could just be place-based, right? Like, anyway, what are your thoughts? Thank you.
Yeah, there's a large literature on social network interventions, which actually haven't really come to large fruition yet because it is so challenging, because you have to have a lot of data to understand the networks first to deploy it. But there's a lot of ideas about how you can leverage that homogeneity, homophily in a group setting to get a whole group to change behavior. And then also finding who has the most power within that group to do that as well. So you're kind of leveraging the social influence that is there to be able to make larger scale change than just the individual level change. The spatial aspect of it is very real, and particularly in public housing, it was interesting to see how many people shared meals and grocery shopped together because they were really relying on their social contacts for that resource. And so you had, who's the person in the group that had the car to go and drive to do all of the grocery shopping, right? Or if we're going to prepare this big meal, who are going to be the ones eating it? So there's a lot of interesting dynamics that are going on there.
I was curious of thinking about place, but in a social media sort of world, and how that changes these dynamics, and if you thought about that.
Yeah, so in the populations that we look at in public housing, we asked about like FaceTiming, how were they connecting with these people that they were naming? And we looked at like Facebook and Instagram, and there's been iterations of studies where we've tried to have an Instagram handle and send messages out that way. We did we had an R21 funded through the NIDCR to look at message dissemination through an Instagram handle and follow who they're sending it to, and if it's people in their network, et cetera. But for these particular populations, it wasn't a main way that they were connecting, interestingly, with the people that were actually impacting their behaviors. There's also a large Puerto Rican and Dominican population in the public housing developments in Boston. And so some of their closest contacts who had the most influence were actually their mother or auntie or cousin who was still in Puerto Rico or the Dominican, right? And they were connecting with them through FaceTime or phone calls on a regular basis. So that was also an interesting dynamic, but we really thought that the social media would be something that would have a big impact, and we haven't been able to get traction there with this public housing community. And again, just by nature of the fact that they're geographically isolated, right? You have these clear boundaries, not just geographically and spatially, but also socially. The developments are often in parts of town where the minute you cross the street, it's a different social class. And so that seems to be where the preponderance of social influence is occurring.
Thank you, Dr. Heaton. I'd like to now introduce our moderator for our second session, Dr. Bashan Davis from the National Institute of Mental Health.
Hi, everyone, in person and online. So I'll be the moderator for this session, session 2, which is entitled Behavioral and Social Science Research Interventions to Address Adversity. We'll be having 2 presentations in this session. The first of which will be by Dr. Justin Carrot, who is an assistant professor at the University of Rhode Island. At the University of Rhode Island, and is funded by the National Institute on Minority Health and Health Disparities. His presentation is entitled Epigenomic Mechanisms or Risk and Resilience, the Role of Parenting.
Okay, thank you, everyone. It's been really interesting. After the last talk, now I maybe need to redo all of my work and consider social networks. But today I want to talk a little bit about adversity and families and that level of influence. Not necessarily addressing adversity, but perhaps buffering it or thinking of that as a context. So I'm going to talk briefly about biological embedding of stress, adversity, trauma, discrimination. And there's been an increasing amount of work in that area, but I'm hoping to flip that and talk about how we can have a positive effect on a biological level. And then we'll end with some not yet even on the press epigenome-wide findings that we're really excited about. Very appreciative of the support we have from NIMHD, loan repayment program, which I think is an amazing resource, especially for people who are from first-gen low-income backgrounds like myself. And also really appreciative of collaborators, in particular Andres, who was there from the beginning and believed in this project. And then also the students who have been really important parts and drivers of this work, past and current students. They're what make the work fun, but they also push me in new directions, which I enjoy. So talking about biological embedding, we've already heard a little bit this on a neurobiological level. But when we think of early adversity experienced in childhood, which can be things like traumatic events, it can be things like living in very low opportunity, very high poverty neighborhoods, violence, as well as racial discrimination. These things confer substantial risk for the development of psychopathology, like anxiety and depression, as well as higher risk-taking behaviors, but also carry lifelong risk for physical health. We see that higher rates of adversity are related to higher amounts of cardiometabolic or cardiovascular disease and shorter lifespans. Unfortunately, what is not political but factual is that this is not equally dispersed, this level of adversity and risk for health and health span in particular. That we see that Latinx and Black youth are nearly 3 times more likely to be at risk for delays in their development. Today I'll talk about early childhood development, but we could think about lots of levels. And not unsurprisingly, Latinx and Black youth are also disproportionately 3 times or more likely to be living in high areas of poverty, have higher rates of adversity exposure. So using the Greater Rhode Island area just as an example, which is very similar to any region you would look at, you see that approximately 75 to 80% of Black or Latinx youth live in these very low or low opportunity neighborhoods, or we can think of that in the reverse, who experience high rates of poverty and higher rates of adversity, whereas only 23% of white families in those regions live in those same low opportunity neighborhoods. What is then a compounding factor of that is that higher rates of risk and adversity then are seen that they also are much less likely to receive services than white children. And this is, I think, a statistic that's jarring, but doesn't even consider the quality or the cultural competence of those services they receive. So I think 5 times is probably an underestimate of those things. And then we want to think about how, and I said it compounded, but really think about the sort of causal and multi-level impacts of immigration, cultural, and race-related stresses and discrimination that underlie why we see these very large differences, in particular redlining and very long-standing historical practices. When we talk about adversity, though, we think about that in sort of lots of levels, but at the biological level, when someone's experiencing high rates of stress and adversity on a daily level in their home environment, we see that chronic and severe stress can have wear and tear effects. And if you're always on edge, or you don't know where you're going to live, or if you will be able to make rent or have food, that's just having that wear and tear on that bodily system that is impacting things like chronic inflammation, as well as that overactivity of our HPA or stress axis. And these stress response systems are importantly responsive to and recalibrating around the environment with a special emphasis on sensitive developmental periods. There's not just one, but early childhood is one we'll talk about today, where these systems are calibrating to their environment. And what may be a short-term, very adaptive response to a threatening environment can end up having long-standing consequences. And one of the ways we think this is biologically embedded is what's through just about as epigenetic mechanisms. So epigenetics, in a very simple, quick way, is the study of changes in the organism caused by modification of gene expression rather than an alteration of the code itself. At a conference, I once saw someone actually bring a slinky, which I wish I had done because it's a cool visual, but you could think about these genes as being sort of tightly packed, and you can't see the inner spirals on that slinky, and then you can see a sort of genes that are more expressed. And epigenetic marks, there's lots of them, but DNA methylation is one that's really highly studied. And you can think of this a bit like a dimmer switch, and that as you get higher levels of DNA methylation, let's say in a stress-related gene, you end up getting decreases in gene expression. And this is thought as this fundamental interconnection between our environment and our genetics or our biology. One of the early studies that's really foundational now is what's shown to the right here, is in a rodent model looking at on the left, this low licking and grooming condition, which we could think of as a neglect or a child maltreatment randomization, which we obviously don't do in humans. And then we have this high licking and grooming, which I would call positive parenting environment. But those who are randomized to this low licking or maltreating environment, they see increases in DNA methylation, especially in this region, NR3C1 or the glucocorticoid receptor. And that's involved with our HPA axis. So we see that when you think of this clinically with children, if they're really stressed, they're starting out more physiologically sort of active, and then they're more reactive potentially to stressors. And then we see lots of fluctuations. But then these changes in DNA methylation then result in changes in gene expression, and then ultimately that's where we get higher physiological reactivity, higher anxiety. So it's really interesting when we think about this in specific stress-related regions, but it's broader than that. And one concept is called epigenetic clock. There are many, many different clocks now, and there's probably more even today since this meeting started. But broadly, we're looking at when we're using very big data. So right now, one of them is called the EPIC array. So something like closer to 1 million different CPG sites, and looking at what are certain methylation regions that really track with aging. And they've created these epigenetic clocks led by Horvath and others that track our aging. So if your clock is faster, that means say you're 35 chronologically, but your body is saying it's 45, you're physiologically aging faster than you should. And one of the things that has one of the most dramatic effects on that accelerated aging is stress, trauma, adversity. And this is really dramatic, and I don't have a slide here, but thinking of where some of this data I'll talk about next was collected in Miami-Dade, we see that the life expectancy between the lowest opportunity neighborhoods and the highest is a decade difference. An entire decade that doesn't even consider the quality of that health and that health span. So what I want to talk about though is what if we could have a positive effect? Could we buffer or reverse the biological impact of adversity? So it's not just a story of you're at risk and we have all these negative consequences, but can we better understand the perhaps positive impact? And I'll talk about families as one level of positive protective or buffering factors. So there's now over 6 decades of research on positive parenting programs, things that help support parents. We know that there's a child mental health crisis, and now more recently, thinking about parents and the stress and overload of parents, and that when there's high stress, it disrupts their ability to be able to provide a nurturing environment that they are providing on purpose with intention, rather than reacting out of more of an automatic pattern of stress and reactivity. So we know that these programs are able to help enhance warmth and positive parenting and praise and structure, as well as reduce some of those harsh, hostile, or physically punishing methods of parenting. And then by a byproduct, we see improvements in parentals, their own well-being, their depression, or the whole family dynamic. So this study that I'm going to talk about today was looking at 3-year-olds living in the greater Miami area, and they're all experiencing delays in development, which is a fairly broad category, but we know that they're at high risk at that age. And they're aging out of these early intervention services, and half of the families were randomized to receive a telehealth, like in-home delivered parenting program, and the others were given referrals as usual, which we'll treat as our control condition here. We're integrating and using the NIMHD research framework, looking at multiple levels. We have neighborhood level, family level, individual level factors, and then we have observations via telehealth before COVID actually, so it was really good timing. But we're using telehealth to observe parent-child interactions, and then saliva collection for looking at DNA methylation. So the sample in total is about 100, but looking at some of these analyses today, it's closer to 71, predominantly Latinx families, which I don't have time to expand on, but thinking about the Miami area, that there's so much diversity sort of within that one term Latinx here. But overall, we see that a majority of the families are living in those low opportunity neighborhoods I talked about. And if we think of those adverse childhood experiences or ACEs or risk factors, it's something like somewhere between 2 and 3 on average. So overall, families were stressed and have higher rates of adversity. About 40% of the families were predominantly Spanish speaking, and then services and assessments for those families was conducted in Spanish. The analyses I'll talk about here are first some of those hypothesis-driven approaches, thinking about aging and stress and inflammation, and then I'll end with our exploratory. So back to that clock, which we don't want to be accelerated. This was a project with the NICHD funded F31 with Ali Sullivan, who led it as a pre-doctoral student. And there's a lot going on here, but I briefly want to show that we have on the x-axis risk factors, which could be things like parental depression, living in high poverty neighborhoods. But as risk factors increase, for the families that have these low, either sort of decreasing or stable low levels of positive parenting, you see the children start out with higher acceleration, and then they either stay the same or maybe trending towards increased acceleration. But the families who increase their positive parenting behavior, and I'll talk about this more, but that's mostly those who are receiving our treatment, saw this actual deceleration in aging as risk increased. And one thing to take of this is actually that at low levels of diversity, there's really doesn't seem to be much of an impact, but it's really at the highest levels of diversity we see the most profound impact on this potential positive effect of biological embedding. And the metric here is like a quarter, or at the highest levels, a half year, but these are again with 3-year-olds. So I think we don't know, but that could really project across the lifespan. This is a little busy. This is our most recent study where we're looking at the epigenetic pace of aging, as well as chronic inflammation. This is work led by Sarah, who's a postdoc and now faculty at UMass Lowell. So on the left, this is Dunedin's pace of aging, which is an epigenetic marker across not just how old are you, but like what's your rate of aging across the different physiological and cognitive systems. And we see overall a higher pace than we might want. So a 1 would be a nice sort of perfect rate of aging. But we see those in our parent-child interaction or positive parenting program, which have a lower level or a lower, slower pace of aging. And on the right is a CRP-based methylation risk score, which tracks chronic low-grade inflammation. And it's believed that this may be an important marker of risk. Again, these are children, but thinking about these children at higher risk as adults for having higher rates of cardiometabolic diseases. And they show that if they're in the parenting intervention program, they saw lower levels of this DNA methylation-based risk score. The last thing is the sort of hypothesis-free approach, looking at the entire epigenome. And it's a small sample, but what I want to show here and focus on at the top is those on the right box or left box, red or blue, that passed a multiple testing correction as well as a technical correction. And I'm going to go into a few details here about these top 24 sites that we see are significantly different between those who received the parenting program and those who did not receive the parenting program. And this is all 1 year after treatment. So if you collapse those 24 sites into a single score using principal components analysis, we see that though our program was able to increase positive parenting and decrease negative parenting behavior, it appears as though those decreases in negatives seem to be driving that effect, but it only partially mediates the effect. So there's more going on here than just changes in parenting. And we're interested in looking at family level factors as well. But clinically, these programs often start with increasing the positive before we decrease the negative. So I think in reality, this is probably more complex than this says. But before we make too much about this finding, we wanted to try and replicate our results across 3 additional cohorts that are doing, although maybe theoretically different, but interventions that focus on the parent-child relationship. So the first is child-parent psychotherapy, which is focused more specifically on trauma, but it's a cohort that was quasi-experimental that matches our kids, similar ages, predominantly Latino. And then the others was focusing on infancy. So now we're going back to even younger kids out in Calgary, and these are mothers who are struggling with depressive symptoms after pregnancy. And the last one is now zooming out to middle childhood. This is Incredible Years program, which is very similar to PCIT. And this is looking at 9 to 12-year-olds. What we did is we looked at a very similar model where we account for baseline levels of methylation, genetic ancestry, cell type proportion, sex, age, and then baseline risk. And we looked to do these 24 sites that we found on this one small sample seem to replicate across different parenting programs. And we were just, I was mostly shocked, honestly, but we were really excited to see that the majority of them do replicate in at least one of these other cohorts, which I think is important for a few different levels. The highest replication is the child-parent psychotherapy, which is similar ancestry and similar age youth. But to see that regardless of the delivery method, some of these were delivered in groups, which is an interesting layer to think about. Some of these are individual programs, but we see that perhaps enhancing the parent-child relationship and family health may be something that we can see across different settings. This was in the United States and Canada and out in Europe. This is, I realize in hindsight, way too busy and not useful, but it shows the different sites. But what these DNA methylation sites that are sort of different between those who did and didn't receive treatment, what's interesting is they're broadly related to genes or have been shown to be predictive of cardiovascular health, growth, and development. So we're starting to see a pretty similar story where we see, cardiovascular health, development, growth, longevity, that these things are all impacted by the family level environment. We have other directions we'd like to go into, including a post-COVID follow-up, but just want to thank a lot of the folks involved in this project and hoping that we'll be able to do more and more will come next. Look for a preprint out later this month on those last findings. Thank you.
I'm going to get over to the microphone and ask a question now.
Yeah.
So I think this is very interesting. I was wondering, and I know this is outside of the scope of your project, but have you looked at the effects or the impact of these positive parenting and increasing these positive relationships between the children on the parents themselves?
Yeah, I'm glad you asked that. We haven't done it yet, but we also asked parents to spit in the tube. Hope maybe just make it all easier for everyone, but that is our next step, is to look at this in parents, to think of this on the whole family level. Although I think it's quite controversial, we're also interested in perhaps this intergenerational aspect. And I think even getting away from the specifics, just the idea that if we invest in children's health, which means investing in families now, can we have an impact across generations, which I think would be really exciting.
Thank you. Are there any other questions?
Hi there, thank you for the talk, super interesting. So given that you found that the child parent psychotherapy populations were the ones which you saw the most kind of replication, and those are populations who by default, they've experienced trauma, they've experienced care, joint trauma with caregivers. So it's a highly stressed population, right? So I'm wondering, do you think that these findings, do you think that the reason for that is that there needs to be some sort of threshold of stress where these interventions are going to be most effective for intervening biologically? Or can you just speak to kind of that context broadly?
Yeah, I think it is very possible, maybe even likely, that if we think about the epigenetic effects being the ones that are most pronounced in those who have the highest risk, because they're starting out possibly with that highest allostatic load, and there's more room. Now, possibly though, if we had a much larger sample, which I would love to do, maybe we'd find effects across the spectrum. But here we're clearly finding effects in those in the highest need, which can guide possibly policy structural level approaches to consider how we support families and how to invest in those who might benefit from it the most. And although we're not getting into it here, also thinking about the cultural level factors, which Adamari is going to be doing as well. So I think there's a lot of layers here to unpack.
Do we have any questions online? So with that, we can thank Dr. Justin Perrin and move on to the next presentation. Thank you so much. So for our next presentation, we'll have Dr. Sanisha Dale, who's an associate professor at the University of Miami. And she will be presenting on the foundation, findings, and ongoing work for the Striving Towards Empowerment and Medication Adherence Interventions for Black Women Living with HIV. Thank you.
Give yourself a round of applause. You're still here. Thank you all for being here. And I do want to give a shout out to somebody who may be leaving quickly, Michael Sterat from NIMH. And I want to give him a quick shout out because he was my program officer on my K-23, which was a foundation for a lot of this work. So thank you always. So to move forward, I'm going to speak a bit about STEP AD, as I say, a couple of disclosures really quickly. I have served in a work group funded by Gilead Sciences on how to best engage people living with HIV. And I am a current co-investigator on a Merck-funded study that is qualitative work looking among diverse women who are placed at risk and have reasons for utilizing biomedical prevention to see what challenges and barriers and options they would like. I always start with this slide. It's not just today, it's every day. And the reason I start with this slide is because when we think about certain groups who are more disproportionately impacted by HIV, it's important to understand that oftentimes the disparities and inequities that we see are driven by systems. And it's driven by intersectional systems of oppression that impact people's day-to-day in terms of their ability to access sexual health care, their ability to access food, transportation, housing, and all these other factors. And because of the lack of these things, people aren't able to get diagnosed as quickly, on treatment as quickly, and their ability to actually sustain and stay in care and benefit from all the medications and other things are limited by these structural factors. So I always like to acknowledge that, because I think without doing so, we always run the risk from a social behavioral perspective of thinking that what we see and what we're learning is strictly due to the individual, which is not the case when we're thinking about health equity. So to just echo a couple of things I just said, when we think about Black women living with HIV in the US, and in particular, I'm going to be talking about Black cisgender women, but Black trans women are also disproportionately impacted. When you look at the map over to the left-hand side for you, the darker areas are areas that have a higher impact and proportion. And you could see I circled Florida there in terms of states that are impacted, which have similarities to other maps when we think about access to healthcare, well-being, and problematic public health policies. And when you look to the right, the one that's circled shows you that among among individuals impacted by HIV, when you think about women, that Black women represent 57%, even though they represent a significantly lower proportion of the population of women. So how does this connect in terms of what we talk about when we talk about STEP AD? These intersectional adversities that are faced by Black women are linked to HIV medication adherence, and it's linked through a couple of pathways. One, we know that violence, trauma, and abuse are linked to people's emotional well-being. It's linked to cognition. You guys have seen a couple talks on that today, and it does impact people's medication adherence, and that's been linked cross-sectionally. Also, racism, we've also seen how experiences and reports of racism are actually linked as well to medication adherence in the work that we do. And we capture both racism in terms of macro discrimination events, such as discrimination in employment or housing, but also in terms of micro aggressions as well, and show linkage with medication adherence. HIV stigma, that's well documented in the literature. Again, it's also linked to medication adherence, and gender-related stressors that women face are also linked to HIV health and medication adherence. And when I speak to gender-related stressors, I'm thinking about not just a strong Black women schema in terms of Black women being viewed and centered as the strength of family units, of communities, and being asked to uplift and be the center and forefront in terms of everyone else's well-being, but it comes with great sacrifice. And so care or self-sacrifice, silence in the self, are other constructs that go along with that, in that Black women are often asked to center other people before their well-being. For the sake of time, I'm gonna skip over that model. So STEP AD, basically what it is, it's a 10-session individual intervention for Black women living with HIV, and it combines evidence-based strategies for trauma symptom reduction, evidence-based strategies such as strategies we commonly see in cognitive behavioral therapy, strategies for coping with racial discrimination, HIV-related discrimination and stigma, and gender-related stressors. There are exercises and a plan that's done at each session to practice and center self-care consistently. So women actually develop plans with the interventionist per week in terms of what they're going to do for self-care, and that includes both things for fun, enjoyment, relaxation, but also in terms of their physical health, things like going to the doctors, calling about appointments, et cetera. And it also includes problem-solving techniques around medication adherence. So STEP AD had several phases. And the way that it started, which I think is important to acknowledge when we're thinking about developing interventions in communities that have been historically marginalized, is to ensure that you are asking the folks who are experiencing the issues and therefore more proximal to how those things relate, despite whether or not you have a shared identity or you have a cool scientific hypothesis. It needs to be from the mouth of the individuals who are more proximal to the issues and therefore the solutions. And so what you see here, and I hope you could read some of them, but I'm gonna read at least one or two. But we did qualitative interviews with 30 Black women living with HIV and 15 community stakeholders. And these interviews asked about their experiences of these intersectional adversities and how they related to taking care of their health and well-being and medication adherence. And so one of the quotes here, she was touching on an experience around racism where she was assaulted, but the cops were called and she was treated differentially and not given empathy, even though she was the one that was attacked. And it was a biased attack as well. She said, I got scratched all on my face. Blood was running down my face. And in the middle of that, when the police was called, you know, they just stood there and looked at me. I'm the victim, and nobody acknowledged that. Being an African-American woman who has HIV, I was traumatized. They also spoke about other experiences such as early childhood trauma and sexual violence. My stepfather used to molest me when I was young, and I've been in abusive relationships. My oldest daughter's father, he used to beat me. I don't see my mom beaten. She's saying that she saw her mom beaten as well, so bad by her stepfather. But they also spoke about the ways in which these adversities were linked to health and well-being. So down at the bottom, you could see those linkages. So one person said, nobody likes dark skin, so I might as well stop doing what I'm doing and just deteriorate. And she was talking about how she had internalized a lot of these acts of racism and othering that she'd experienced around her Blackness. And so that thoughts like this at times would cross her mind. Another person said, I would skip appointments and miss appointments because I didn't want to deal with the subject. So dealing with HIV, thinking about HIV and being stigmatized due to HIV. Another person said, I wouldn't keep my appointments because I was doing something else for someone else. I wanted their approval and I wasn't taking care of myself. So going back to the care of self-sacrifice piece. But something else that consistently also came up in these qualitative interviews were that women were also speaking about the ways in which they were coping. And although there aren't a lot of quotes exemplifying them here, that actually became the anchor for a lot of the coping strategies we talk about in the actual intervention itself. And one of the ones that were consistent were that women spoke about having an internalized power and strength that they had to discover and hold on to be okay in spite of everything. I'm a strong individual and I'm going to continue to be strong, continue to live no matter what you think about me or my color. I'm going to show them, I'm going to try to look good, be healthy, be active, regardless of what nobody thinks. I'm going to do what I got to do to survive with this HIV. After the qualitative work, we then did an open pilot study among 5 Black women living with HIV, where we essentially took them through the intervention and also did a lot of exit interviews and qualitative work after to see what they thought about it, again, in terms of feasibility, acceptability, any additional pieces that we needed to tweak. And what you're seeing here on the left-hand side is their trauma symptomology and what was happening over time among those 5 individuals. By the way, if you love literature, love Black women writers, the names are on purpose. But when you look there, you see that their trauma symptomology was fluctuating at different times. So it would go down, it would go up. What was happening was that woman was also sharing with us instances about being re-traumatized or forced evictions, but also a lot of daily microaggressions and other things. So long story short, this actually finding here led to some other work that we currently do that's a longitudinal cohort following women over time. But nonetheless, when you look at the women's trends collectively, their trauma symptomology was going in the right direction in terms of going down. And then when we looked at the medication adherence, we saw blips that correlated with what we're seeing in terms of the stressors and stuff that were reoccurring for women, but it was still trending in the right direction. We then moved on to do the pilot RCT, where we then randomized women to get step AD or they got an ETAL. And so the ETAL is enhanced treatment as usual. And essentially what we did for the women who were in those control conditions was that they still got a 1-session brief intervention around medication adherence and problem-solving strategies. And this is something we do a lot in my SHINE research program, just out of ethics. There has to be something, it can't be anything that we're giving women. And they would still come in bi-weekly where they would check in with our team, complete surveys. And if they were to indicate issues that were coming up, by nature, across the board, we have a community resource guide that participants are walked through and connected with if there are issues that are of relevance that they're bringing up. So both women in the intervention and the control had access to that. And this is the allocation table for how women went into the intervention. I'll just say this quickly. We had high retention across both conditions. I think we lost 3 people only across both. And so we had relatively higher retention. These were some of the measures that we utilized. We utilized the WISE medication monitoring device to track medication adherence for their ART meds. There were self-report measures. We measured their viral load and dichotomized it, as well as looked at it in terms of linear and log. And we looked at CD4 count. And we also did clinical interviews to look at their PTSD symptomology and diagnosis. And we had a self-report measure on PTSD. So for the pilot RCT, we did a difference in difference analysis where we compared women in the ETAL to the women in STEP AD. And what's cool about different diff is that it helps you to control for the baseline differences to ensure that what you are assuming is a significant change is actually more related to what you did in the intervention and less about what may have been present at baseline. These are some of the sociodemographics. There weren't much significant difference between the sample at baseline. So they were very, very similar in our regards. I think one of the very minor things you might have noted was that there were a few women who were LGBT identified, and that maybe it was kind of like a 2-1 scenario where a couple of them were in one condition versus the other. And what we found is that when we did the different diff, this is a plot showing you the graphs for medication adherence for women in STEP AD, which is blue, and then ETAL, which is purple. And we found that there were significantly higher heart adherence for women who were in STEP AD by the end versus women who were in ETAL. There was also significantly lower likelihood of being clinically diagnosed with PTSD. And something I want to note about this is that usually the evidence-based treatments like CPT and PE, which is prolonged exposure and cognitive processing therapy for PTSD, are several sessions in and of themselves, so like 10 to 12 sessions. But actually for STEP AD, we only did specific trauma-focused work using CBD, sorry guys, I guess I'm fatigued too, cognitive behavioral therapy strategies really for 2 sessions. But what we did was that we applied a lot of the tools and skills women were learning were talked about cumulatively. And so we talked about their traumas such as sexual abuse or assault in the same breath that we talked about the trauma from racism, the trauma from sexism, right? And so when women would go through each of the sessions and be addressing and talking about ways that in which they were coping, these strategies would still stay, even though we weren't explicitly just focusing on the typical criteria in A trauma. So it was actually really cool to also see that there was a significant diagnosis in PTSD for the women who were in STEP AD compared to ETAL. We also saw borderline significance on higher CD4 count for women who were in STEP AD compared to ETAL. Conclusion and next steps. This body of work is something that is very dear to my heart, and I think it is dear to my heart because of the foundational pieces of how it developed. But I think for me too, it is seen for the women and for the folks who have helped inform this work, say at every stage how it's impacting them today. Ironically, and I know we're in NIH, no politics, but ironically, this morning when I woke up, I thought of women who've gone through this intervention with me, because there have been times that have been very hard in this country and in spaces and the things they've gone through. And this intervention has allowed them to name and talk about things that are very real for them. And it's not all the time that as providers and as people who are interfacing with them, that we create courageous and bold spaces to say that you could be all you are in this space and you could talk about the systems that are in fact hurting you. Right now, we're conducting a large-scale randomized controlled trial of STEP AD that's funded by NIMH, and we're really excited about all the ongoing work. These are members of my amazing team. There've been many before, but we just took some new ones here, and I want to acknowledge my collaborators as well, community partners, and of course, NIMH. And thank you all again for sticking around. No lie, I might have gotten up if it wasn't me going last.
I think we have a brief amount of time for a few questions. So if anyone has
Thank you. That was excellent. Really nice presentation. So just because the pipeline, right, from research to practice can be such a slow drip as we saw earlier, I was wondering if in the current trial that you're running, if you're thinking about implementation and implementation factors as a way to try to speed scale up a little bit.
Exactly. Yeah, there are some elements that we're trying to look at in terms of monitoring costs. another perspective. And it's interesting because I think that with one of my current R01s, the large scale implementation trial, and when submitting this R01, initially we wanted to go in and do it in a community-based health center. And in all honesty, the collaborators who are perfectly poised and it would make sense there, said that both the timing and the needs and a lot of other moving parts that were happening, that sometimes even though we try to move those parts and piece the part in terms of implementation, it's still, research can still be a burden and a competition to the raw services that they need to provide. And so yes, I'm very much thinking about what will this mean for the next steps of getting it in community. The other thing about Step AD that we're doing, that others have given us feedback on, and we're gonna do focus groups and other things, is that it is being self-contained and sort of feel modular. So folks have we've been able to say, well, this is the issue coming up for you, and swap it and do another session at other times. And so I think that modular-like approach to it may also make it so that it's something that's implementable. Again, qualitatively, people love it, but it's not something we're able to do with the partners that made the most sense in this instance. But I hear you fully. Others? Thank you all again. I appreciate you all. Yes.
So now for closing remarks, I believe we're going to have Katie Morris, who is the Chief of Policy Planning and Analysis, the Policy Planning and Analysis section at OBSSR. Hope to close this out. Thank you.
Thanks, Vishon, and thank you so much to everyone for the great presentations and great discussion today. It's been really engaging and exciting to see. And I just wanted to make sure we took some time before everyone heads out and decompresses and reloads the information from today, to thank our planning committee for the festival, particularly Vishon Davis from NIMH, Clay Nash from ECHO, Elizabeth Sharma from NCI, Reagan Bishop from NHGRI, and our OBSSR colleagues on the committee, Dana Schlosser-Green, Michael Spittle, Kathy Malsby, Lizette Rivera-Arnold, Tamara Hagerich, and Marie Rienzo. But most of all, we want to thank our program officers here at NIH who are recommending these presentations and able to get us the best research so we can all see it here. But make sure to join us tomorrow after you've head home and relaxed and taken care of yourselves. We're starting again at 12 for the networking in person, but then at 1 o'clock here and online will be a fireside chat between our director, Dr. Jane Simoni, and the director of NIDA, Nora Volkov. And that'll just kick off all the presentations for tomorrow as well. So thanks everyone, take care.